So, a very good afternoon to all the respected delegates. So, we are about to start our first clinical meeting of the year 2024. So, like every year, we usually conduct the clinical meetings in different places of West Bengal and of Kolkata and outside. And usually, this is basically a platform for the juniors, these residents, and the postgraduates to just have a sort of rehearsal so that they can present in larger platforms in a more confident and more comprehensive way. So, like the every clinical meeting, we have judges. I would like to request our judges, Dr. Bidhan Rai sir, to Dr. Shubhajit Banerjee sir and Amitabh sir, so to please come on the dais and take the seats. Shubhajit sir, Amitabh sir. And the rules and regulations of the clinical meeting are every presenter will have a presentation time of around 8 minutes and there will be a question answer time of 2 minutes. No questions from the audience is allowed. Audience can only comment on the presentations. And at the end of the presentation and at the end of the question. Okay, so at the end of the our all presentations, that means we are having 10 presentations today. So at the end of 10 presentations, the audience can comment regarding their area of interest to encourage the juniors. Now, another important point that is important here to mention is that these clinical meetings is usually organized round the year. And among the topmost among the participants who score or who becomes the first one or the winner, he get a prize in the name of our Gurtu sir. So Gurtu sir is present here. Thank you very much, sir. So without wasting much time, I would like to invite our first speaker of the day. He is Dr. Bapaditya Kaur from RKMS. And his topic is parathyroid adenoma, a diversity of presentation. Bapaditya.
Good afternoon,
Hello.
everyone, judges, respected seniors, and my fellow colleagues. I am Dr. Bapaditya Kaur, and today my topic of discussion is parathyroid adenoma, diversity of presentation. So we are broadly discussing about primary hyperparathyroidism. The main causes are parathyroid adenoma, parathyroid hyperplasia, and parathyroid carcinoma. They manifest as multi-system clinical picture as bone deformity like osteoporosis or bone fractures, nephrolithiasis, hyperuricemia, or GI disturbances like stomach ache, constipation, neuromuscular pain, and some cardiac manifestations are also there. Now my first case is a 49-year-old female presented with a fracture neck femur at our orthopedic casualty. She had a history of parathyroidism and hypercalcemic crisis with a raised parathyroid and calcium levels. No other systemic illness was there. History of cholecystectomy 15 years back, and LUCS was there. Patient underwent right arthroplasty with subsequent hip nailing, and USG and parathyroid scintigraphy was done to reconfirm the diagnosis further. And when the patient came to us, we did a neck examination that was unremarkable, and fiber optic laryngoscopy was also done. The reports were unremarkable. Now in the USG finding, we can see there is a solidocystic SOL here at the right posterior inferior aspect of parathyroid gland, lower lobe of right parathyroid, TIRADS 3 grading. Now, and this is the parathyroid scintigraphy and SPECT CT done to further reconfirm the previous diagnosis, which corroborates with the site in terms of site and size, like the same size we got in the USG. CCT neck was also done, and oval SOL is noted at the same site, right posterior inferior aspect of parathyroid lobe. There is this measurement, and a small but similar lesion is also there in the left lobe. So impression is bilateral parathyroid SOL, larger on the right side. And also there is a large expansile lesion in the posterior end of right fourth lip. We can see here the lesion that suggests of brown tumor. Bone mineral density was minus 3.4 and fiber optic laryngoscopy findings were unremarkable. Now this is the operative video. After sending the IPTH level, we give Kocher's incision and we left the subplatysmal flaps very carefully. After that, flaps are elevated. We retracted the lower pole of thyroid and the adenoma became prominent. There, we separated the adenoma very carefully. There, got very carefully and dissecting the interglandular branches and recurrent laryngeal nerve throughout. We didn't touch in the medial part. We just peripherally dissected the adenoma very carefully, and after dissecting it totally, we send it for HP, and the same procedure was done in the left side. And soon after the operation, within 10 minutes, another PTH was sent to assess the surgical outcome. HP came as parathyroid adenoma for this patient, and after the operation, serial PTH, blood calcium and blood phosphate level were estimated, and where we can clearly appreciate that there is a remarkable reduction in PTH level post-operative period, which is maintained throughout the 6 weeks of post-operative follow-up. And there is also a reduction in calcium level, which is stabilized over 6 weeks in the post-operative period. Then patient discharged after 6 weeks with vitamin D3, folic acid and iron supplements. So this is possibly a case of transient hypocalcemia in a case of post-operative parathyroidectomy. Now my second case is a 58-year-old female with history of hyperuricemia and nephrolithiasis and positive family history, presented with increased serum calcium and PTH level. She is a diagnosed case of primary parathyroidism with no other systemic illness. History of appendicectomy, LSCS and THBS were there. In this case also, we did USG and scintigraphy to reconfirm the diagnosis, and when the patient came to us, we did neck examinations and a routine fiber optic laryngoscopy that was unremarkable as well. In this case also, we can see the SOL in the USG. This is a cystic lesion in this case, in the posterior inferior aspect, query parathyroid origin. Cestomy scan was done that reconfirmed our diagnosis as lower parathyroid adenoma. There is also CT done where it came as a elongated SOL, posterior inferior part of the gland here, this one. So after diagnosing, we move to the operation, and the same operative procedure and protocol is being followed. In this case also depicting the parathyroid adenoma. So without dealing further, I am moving to the next slide. HP reconfirms our diagnosis in this case also being parathyroid adenoma. And in this case, when we estimated our PTH and blood calcium level, we came across that PTH level is decreased, but neither satisfying the Miami criteria nor well maintained as in the previous one. And in case of blood calcium level also, this is a very variable blood calcium level we seen in the postoperative period of this case. So the patient is discharged after 6 weeks follow-up with cinacalcet, calcium-eating agent, and this is possibly a case of parathyromatoses due to intraoperative seepage of parathyroid granules. So discussion, parathyroid adenoma relatively a rare condition. Major causes and clinical presentation I already said in my first slide. Sonography and cestomy scan is the primary modalities for diagnosis. MEB scan yields 90% sensitivity in localizing this adenoma. Surgical excision is the recommended treatment. Intraop localization is done by PTH assessment, gamma probe and intraoperative methylene infusion. Miami criteria defines successful removal. Postoperative persistent high PTH can be due to transient hypocalcemia, Hungry bone syndrome, parathyromatoses, and even parathyroid carcinoma. Known complications are postoperative hypocalcemia, persistent hypercalcemia, recurrent laryngeal nerve injury, and hematoma. Now, the take-home message is hyperparathyroidism presents with a wide variety of symptoms. Management is combining clinical correlation, CCT and MEB findings, and involving a multidisciplinary team. IPTH estimation is done to assess postoperative surgical outcome. And very importantly, care is to be taken to avoid spillage during the operation. These are my references. Thank you.
Okay, Dr. Kaur, it was a nice presentation. Now,
Thank you, sir.
Do you just find all the other 3 parathyroids were normal while operating? You have just taken one parathyroid gland in question.
Sir, we took 2 parathyroid gland in the first OT,
Okay, and the third
both in
one?
lower lobe,
Oh.
and in the second OT, we took only the right lower parathyroid gland. As it is came in the scans, previous scans, the lesion is only there.
Do you expect adenoma to be on the 4 glands, parathyroid glands, sometimes?
Yes, sir.
Is
It can happen in terms of hyperplasia, parathyroid hyperplasia. There can be the 4 gland enlargement.
Hypertrophy. And what will be your management, surgical management then?
Surgical management then will be the bilateral neck dissection, sir. Bilateral neck dissection, each corner of the thyroid gland we have to separately exclude the nodes and.
No, I'm just asking you about what, do you remove the 4 glands, 4 adenomatous glands at a time?
No, sir. We will try to preserve half of a gland for further to prevent further hypocalcemia.
Okay.
In either in brachioradialis or in sternocleidomastoid, whichever is there possible for us to do.
Is there any other surgical procedure where you can just address the adenomas? Any other site you can approach?
Yes, sir. We can approach transaxially. Transaxially, sir. Axilla. Axillary.
Another one?
Another one.
Not common in our country now, but in this country, okay. Transoral sometimes, okay.
Orally.
Orally.
Oral sometimes. Okay, sir. Right, sir.
Okay, just imaging of choice in the case of parathyroid adenoma. You have told that it is USG and technetium 99.
Right, sir.
So just can you tell me the sonological features of a parathyroid adenoma? What we get, usually what you get through ultrasonography in a case of parathyroid adenoma, so that we can differentiate it from a case of primary parathyroid hyperplasia. Those are little bit two different entities. One
Right,
is
sir.
parathyroid adenoma, another one is primary parathyroid hyperplasia. Sonologically, can we differentiate? If it is so, what are the differentiating features, or what are the
Sir.
features of? Yeah, just tell me.
Sir, we can estimate, if not permanently decide, we can estimate because in sonography we can see solidocystic SOL in a particular place. And in case of hyperplasia,
Is it capsulated?
it is well demarcated, sir. In sonography, well demarcated is there.
Yeah.
There is well demarcated solidocystic SOL or only cystic SOL is there in sonographic finding.
Did
And
you
in
get
case-
anything in the pericapsular region, a rim of?
Sir, there pericapsular region I found enhancement in blood vessel enhancement was there, and sometimes microcalcification was there also.
Now, there is one characteristics which can differentiate a adenoma from a parathyroid hyperplasia, is that a peripheral rim of hypocellular non-tumorous tissue, which is present in parathyroid adenoma, which is not present in cases of parathyroid hyperplasia.
Right,
So, number one. Number two, usually we don't need any sort of cytology or biopsy in diagnosing parathyroid adenoma, isn't it?
Right, sir.
Is there
Okay.
any such case where we do need it?
Sir, as per I went through to confirm the diagnosis, HP is well enough. And previous
HP is post-excisional.
pre-op,
Yeah,
you
yeah,
are saying.
yeah.
Pre-op, sir, I came across that the diagnostic modality when used together, like in USG and systemic scan, if we use together, the sensitivity of the testing modality is around 97%.
So, to
we can,
summarize, what are the diagnostic features of a parathyroid adenoma in sonology, in biochemistry and clinics, everything? Just tell me once again.
one sentence, sir.
No, once again actually.
Once again.
Clinical features, sonological features and biochemical features, just which can lead to the diagnosis.
Like, sir.
Yeah.
In biochemical, firstly, clinical feature. In clinical feature, we can see, like, sir, skeletal manifestations we can see, like osteoporosis or previous history of injuries or fractures, like in the first case. Or in case of renal manifestation, we can see nephrolithiasis, hyperuricemia, or reduced creatine clearance we can see. In case of GI disturbances, we can see stomach ache is there, constipation is there. In case of Neuromuscular pain is there.
That is classical stone bone and groan.
Yes, sir. Stone
Okay.
bone and groan.
Then sonology.
And cardiac manifestations are there. High BP is there. Tachycardia is there. They are cardiac manifestations. Clinically, in biochemically, sir, we can see increased calcium and parathormone level and decreased phosphate level.
Okay, thank you.
I would like to request A.M. Shah sir, please come on the dais to give the certificate to Bappa Ditto.
And any questions or suggestions from the audience?
It's a very misconception that every time you do a parathyroid surgery, it's going to come down immediately. It doesn't. In 1/4 the cases, it will take some time for the calcium hemostasis to settle back again.
Right,
The
sir.
bone is hungry, right? There's a
Right,
hungry
sir.
bone syndrome going on. So it will take some time.
In this case, sir, it was not a hungry bone syndrome, but
It
yeah,
does
there
take
are
some
differentials,
time.
right,
so,
sir?
it's not always necessary that you've done a parathyroid surgery and it's going to be normalized within a month. It
Right,
doesn't.
sir. Right, sir.
Very well point taken. Thank you very much. We proceed to the next person.
Just one point again. As in your second case, I am speaking here. In your second case, it was a family history positive. So whenever there is a family history positive, you should also exclude MEN syndrome, MEN 1 and 2A. That we have not done in your cases. Okay? It was only one suggestion was required.
So our next presenter is Dr. Progya Paramita. Her topic is endoscopic assisted intraoral resection of a mesenteric mass.
Good afternoon, respected judges, seniors, and my dear colleagues. I am Dr. Progya. I will be presenting endoscopic assisted intraoral resection of a mesenteric mass. We had two patients. The first was an 18-year-old male, resident of Andaman and Nicobar Islands, and the second patient was a 24-year-old female, a resident of West Bengal. The 18-year-old male presented with a left-sided cheek swelling which persisted for approximately 20 months, which was insidious in onset and gradually progressive in nature. It was not associated with any history of pain. There were no specific aggravating or relieving factors, and there was no history of trauma. The 24-year-old female also presented with similar complaints, except for there was a past history of trauma present. On the clinical examination, on inspection for the first case, we found a 2 into 3 centimeter globular swelling, the margins of which were well defined in the left cheek region. The skin over the swelling was not associated with any redness or no associated skin changes. On intraoral examination, the swelling protrudes into the oral cavity opposite to the left upper premolar. On palpation, the size of the swelling was 3 into 4 centimeter, globular, well defined. It was cystic, non-pulsatile, and non-tender. It was located in the left cheek region opposite to the left upper premolar. For examining the fixity, it was not attached to the overlying skin, was attached to the underlying muscle. There were no neck nodes palpable. On percussion, it was dull, and the auscultation, no bruit was heard. The similar findings were also present for the case 2, except for the swelling was 1 into 1 in centimeters. Investigations. The first case, the fine needle aspiration cytology revealed a bloody aspirate with only hemorrhagic material. The MRI neck was done, which suggested a well-defined intramuscular space-occupying lesion, as we can see, with features specific of soft tissue cavernous hemangioma. An MR angiogram was done, which revealed no AV malformations or aneurysmal dilatations. It showed a T2 hyperintense space-occupying lesion in the left mesenteric region without any feeding vessels. For the case 2, a plain and a contrast MRI was done, which showed a well-defined lesion in the left mesenteric region, which was hyperintense on T2 weighted images. And it also, the post-contrast study revealed intense patchy enhancement, as that can be seen. The differential diagnosis of the swelling could be a parotid gland space-occupying lesion, cervical lymphadenopathy, lipoma, a dermoid cyst, a sebaceous cyst, hematoma, or any mesenteric hypertrophy. For management, both the cases were treated using endoscopic assisted intraoral excision. This is the operative video of the first case that shows first we had an infiltration done, which was followed by the incision, mucosal incision 2 centimeters approximately, which was further followed by dissecting the mass from the surrounding tissues. The anterior aspect of the lesion was exposed with gentle dissection and complete enucleation was being performed. Vascular hemostasis was achieved, followed by the complete excision of the mass in toto. The mass was then further sent for histopathological examination. For the post-operative care, for the next 24 hours, no mouth rinsing or brushing was to be done. Soft diet for the next 24 hours, which was followed by normal diet. Rinsing of the mouth with warm normal saline for at least 6 to 7 times per day for a minimum of 20 days. Normal brushing of the teeth was started after 24 hours to prevent any food lodgement that could be a source of infection. The final histopathological report for the case 1 was an atriovenous malformation, and for the case 2, it was a cavernous hemangioma, both of which are benign. Now, hemangiomas are benign vascular proliferative lesions. Intramuscular hemangiomas constitute less than 1% of all hemangiomas, of which 10 to 20% are present in the head and neck region, of which 36% of the tumors usually arise in the masseteric muscle. According to Azar et al., reported that only 0.8 to 1 to 2% of the tumors are malignant. The preoperative diagnosis of intramuscular hemangiomas of the masseter is problematic because they can be confused with other space-occupying lesions of the parotid and other muscular lesions. MRI provide a better imaging modality because they can help us delineate the tissue from the surrounding structures. Intramuscular hemangiomas are typically seen among adolescents and young adults, of which they have an equal preponderance in the male and female distribution, except that the masseter involvement is typically has a male preponderance. The pathogenesis of the intramuscular hemangiomas can be described by having a malformed tissue that has undergone a repeated trauma or is under any hormonal influence. Because of their deep location, definitive pathognomic features are a bit difficult to exhibit. So they do not exhibit signs like pulsations, thrills, bruit, which makes its diagnosis difficult. Xiaofang et al. Reports that the complete surgical excision of the masseteric mass is the standard treatment. Although intraoral approach can be performed to resect the masseter mass in the buccal space, it is one of the very challenging approaches. The principal difficulty is the reduced surgical field. When a classic intraoral approach is performed, the exploration can be better. The external approach also carries a very high risk of injury to the facial nerve and a visible facial scar. To select an appropriate approach, there should be a balance between the surgical safety and cosmetic consideration. So, a minimally invasive approach should be considered. With the gaining popularity of the minimally invasive surgery around the globe, the risk of injury to the marginal mandibular and the facial artery have reduced significantly. The endoscopic assisted approach offers a very good intraoperative illumination and excellent magnification, which thereby permits a safe removal of the mass. It also provides better cosmetic outcome due to the absence of any external scar. It also provides a good control to prevent injury to the major structures in and around the mass or the facial, like the facial artery and the marginal mandibular nerve. Moreover, a complete resection of the mass could be done without causing any injury. These are my references. Thank you.
Thank you, Dr. Purga. It was a nice presentation. When you can't do it intraorally or endoscopically, there are some conditions where you have to approach externally. Can you tell me?
Sir, intraoral, to approach intraorally, we need to have a proper mouth opening in that patient. If the patient is a case of trismus or there is any associated difficulty of the opening of the mandible, the intraoral approach becomes a bit more challenging and difficult. In that case, we have to approach the patient from externally approach.
What is the insertion of masseter muscle?
So the masseter inserts in the lateral aspect of the ramus of the mandible.
Can we just do it in endoscopically? Can we see it in a 0 degree or 30 degree? You have used the endoscope.
Sir, we have used a 0 degree scope here.
0 degree scope.
Yes, sir.
Just one thing, what is the logic behind no mouth rinse for the first 24 hours?
Sir, initially we have secured it with sutures. So and also if there is any blood vessels that are temporarily stopping the vessels from bleeding. So first day if we go for rinsing, it may dislodge and there can be bleeding, or there can be any other
Do
injury.
you find it from any other literature that this is being advised or this is being practiced regularly in a post-operative period?
Sir, I have consulted this from the maxillofacial department,
Yeah.
and these are the suggestions that they have provided.
So you are using a 0-degree endoscope and
Yes.
conventional cold instruments, isn't it?
Yes, sir.
Yeah. Do you find any advantage of using this apart from the headlight or loop? As because conventional cold instruments are not meant for endoscopic surgery, but you are using it. Somebody is everting the cheek, somebody is lightening the, but why are you wearing the headlight?
So,
The use of headlight was there or not? Or only endoscope was there?
so we did it using the endoscope.
You hold the endoscope in your left hand and you are using the conventional cone instruments in your right hand.
Sir, once one of the operating surgeons was holding the endoscope,
Yeah.
and other operating surgeon was operating the surgical field.
Yeah, so you need a 2% or 3-hand or 4-hand assistance here actually. Okay.
Thank you.
Thank
sir.
you.
Thank you, sir.
Any comment from the audience? I would like to request Dipankar Mukherjee sir to please come on the dais to deliver the certificate to Progga.
Right. I just have a small thing to note. Endoscopic approach to many of these benign tumors of the masticatory space is becoming very common. In fact, there is a series which is being published from TMH itself where they've done a number of cases very similar to the two that you have shown over here. The only difference is that over there they also use long harmonic instruments just in case it helps for hemostasis. At the same time, we also have a development of the TAUS approach, that is a transoral video-assisted ultrasonic approach, but that is more for oropharynx, base tongue, and tumors of the supraglottis, and it is coming up as a very good alternative to robotic. Every institute cannot have a robotic thing because of the high costs. And most of our surgical departments, we are having long harmonic instruments and we have our endoscopes. So all you need is an endoscope holder and you need this instrumentation. So this is definitely a very good evolving approach to lesions of the oral cancer and of the head neck region.
So another point, I think this is that come to my mind, that the facial artery is another thing. The facial arteries sometimes come into the way, so you need to be cautious about damaging the facial because it's become very difficult to control the bleeding intraorally. Our next presenter is from Command Hospital, Dr. Ancy B. Abraham. Her topic is cochlear implantation in subtotal petrosectomy, the pulse of wisdom. So, chronic otitis media cannot contraindicate the procedure. Come.
Good afternoon, respected judges and members of our medical fraternity. Today I will be speaking on cochlear implantation in subtotal petrosectomy and the pearls of wisdom. The cochlear implantation candidates with chronic otitis media require special attention and management. The challenges which are faced is increased chances of infection to the subarachnoid space, carries the risk of meningitis and surgical site infection, and also with the history of multiple previous surgeries, it can make the CI surgery difficult. These challenges can be overcome by subtotal petrosectomy, which was first described by Rambo, popularized by Fish, and has been recently accepted by the cochlear implant surgeon community. There are many indications for subtotal petrosectomy combined with cochlear implantation, but we will be focusing on the cases of chronic otitis media, cholesteatoma, and presence of a radical cavity. The advantages of subtotal petrosectomy is it brings the complete eradication of the disease, it provides an isolation of surgical cavity from the external environment, it gives good illumination and gives an excellent control of the landmarks and allows easy maneuvering of the electrodes. The aim is to describe our experience in cochlear implantation with STP in cases of chronic otitis media in terms of the indications, complications, and surgical issues. Also, we have learned from the experience and applied it in one of our representative cases. This is an ambispective interventional study, all cases of COM who had underwent CI with STP by the same surgeon at 2 tertiary care centers between the last 4 years and were included and were followed up for the next 1 year. The demographic data was collected, indications were seen, surgical techniques and complications were noted, and the conclusions were drawn and applied on our clinical case. This is a busy slide, but I'll make it a bit simpler. There were total 8 STP with CI, out of which 3 were female and 5 were male, 6 were right-sided and 2 were left-sided. The 4th and the 6th is the same patient who had undergone bilateral procedure. There were various indications which were atelectasis, previous mastoid cavity, discharging ear, multiple surgeries. We have seen that in these, the complications were blind sac dehiscence, which was noticed when only the external auditory canal skin was used instead of using the tragal cartilage together to reinforce it. Also, in previous mastoid cavities with deficient subperiosteal layer, while giving an L-shaped incision, it led to the implant exposure. And fat, which was used for the obliteration of the cavity, it led to surgical site infections. The pitfalls in the previous 6 cases were seen, and we gained pearls of wisdom and used it in our index case. The lessons were learned and henceforth utilized in our representative case. A 24-year female with the complaints of bilateral ear discharge since childhood, who had underwent multiple bilateral ear surgeries, who had a previous episode of labyrinthitis and had an hospital admission as well, and despite taking all the medications, her hearing could not be recovered. Hence, she was assessed clinico-audiologically and diagnosed as a case of bilateral COM squamous right active, left inactive with bilateral profound hearing loss. The best preparation for tomorrow is doing our best today. So the issues we faced were disease clearance and profound hearing loss in the right ear, and we had planned her for 2-stage surgery. Due to the multiple previous surgeries, there was lack of musculoperiosteal flap. Hence, we took a retroauricular incision which was extended 2 to 3 cm posterior superiorly, keeping in mind that the same incision will be used in the 2nd stage surgery. Also, it also provided the place for the receiver stimulator placement, and also by covering it with the temporalis muscle, it prevented its extrusion. The blind sac closure of the external auditory canal was performed, and it was reinforced with the reflection of the tragal cartilage to avoid blind sac closure dehiscence. All of the external auditory canal skin and middle ear mucosa was removed. Aggressive drilling of the anterior inferior wall of the external auditory canal was performed at the level of the bony annulus to avoid leaving any skin debris. The facial ridge was lowered and complete exentration of the air cells was done. A silastic sheet was placed in the middle ear to guide during the 2nd stage surgery. The patient was kept in close follow-up, and after 6 months, imaging was done to rule out any recidivism. On HRCT temporal bone, facial nerve was seen lowered down. Basal tone of the cochlea was patent. However, few perisinus cells were present. On MRI, it showed no evidence of recidivism. On diffusion-weighted imaging, there was no signal restriction, hence ruling out recidivism. 2nd stage surgery for CI was planned. If there was any microscopic evidence of recidivism, it was planned to be cleared out, and if the perisinus cells which were present, it was utilized for drilling and creating tunnel, thus securing the extra cochlear array. The lower limb was also prepared in case if temporalis muscle flap could not be used. The temporalis muscle was initially taken for cavity obliteration, hence avoiding any extra scar. Preoperatively, facial nerve monitor, TISL, neural response telemetry, and C-arm were kept in hand. The incision was incorporated into the previous surgical incision, and soft tissue dissection was done. A relatively more posterior pocket was created for a receiver stimulator. The silastic sheet, which was previously placed in the first surgery, was identified and gently removed. The various landmarks were identified. Round window niche was present. Facial nerve monitor was used to identify the horizontal and the vertical segment of the facial nerve. The perisinus cells were drilled to make the tunnel for housing extracochlear array. The electrodes were inserted into the cochlea. Temporalis muscle rotational flap was utilized to obliterate the cavity, and it was strengthened by utilizing tissue. The bone dust was used to cover the electrode array. The C-arm imaging confirmed intracochlear electrodes and NRT was within the normal limits. The patient hence awaits left ear surgery. The literature describes various schools of thoughts in regarding to staging and techniques, single versus two-stage, use of fat versus muscle flap for obliteration. Szymanski et al. In 2016 has described an algorithm for the single-stage versus two-stage surgery. In dry COM, one should use single-stage, and in the discharging ear, one should go for the two-stage surgery, as was done in our case. The key points learned were the incision should be incorporated in previous incision. The silastic placement in the middle ear helped in identifying the landmarks. Well-prepared previous surgical cavity helped in better identification of the round window. Tunnel preparation utilizing the remnant perisinus cells helped in better electrode placement, and the temporalis muscle rotational flap decreased the chances of surgical site infection and avoided extra surgical scar. This is a glimpse of an emotional moment in our hearing speech clinic. The mother went deaf during speech development of a child and was not even heard her son calling her Amma. This was the ultimate gratification from our job well done. To conclude, STP is a safe and effective surgery. Meticulous surgical technique in form of well-planned incision, complete removal of disease, and careful covering of the implant is key to success. Although it was a small study population, but our study will add to existing literature. Thank you.
Thank you, Dr. Abraham. Because it is a case of subtotal petrosectomy,
Yes, sir.
so, how do you address the round window niche to just put your arrows of electrodes? Do you find it a bit different from a normal cochlear implantation program?
So in this case, we had placed a silastic sheet which allowed us to identify the middle ear structures, and on pressing on the stapes, we could see the round window niche.
Do you have to address the promontories like?
Yes, sir.
The promontory should be kept like?
Yes, sir.
Thank you. It's a very nice study.
Thank you, sir.
A couple of questions. First is, you are checking the disease clearance and recidivism with MRI. What are the things that you would be looking for? For example, what are the features of recurrent cholesteatoma or epithelial pearls in a MRI?
Sir, in MRI, we will be able to see an hyperintensity in the obliterated EAC in the cavity. In that we can see through the MRI, sir. In diffusion weighted MRI, we will see if there is any restriction of the signals. So that will rule out the recidivism, sir.
Okay, and one question. You said you're covering with bone dust the electrode.
Yes, sir.
How do you collect the bone dust, and are you worried about infection or epithelium or anything while you collect these? Where do you collect it from?
So while drilling, we had taken out the bone dust.
No, actually you need to, a surgeon needs to be careful about collection of the area
Yes,
from
sir.
where he is collecting and how the bone dust is being collected,
Yes,
because eventually there is chance of squamous epithelium embedded in the bone dust. So it has to be a clean area, and there should be a bone dust collector ideally, which will prevent contamination and also accidental epithelium into the bone dust.
Yes, sir.
And the last question.
Yes, sir.
In a primary surgery, patient comes with a cholesteatoma, and what would be your recommendation after your experience and study to do first stage or second stage always?
So if a primary surgery patient has come as a cholesteatoma
For a
with the
cholesteatoma
recurrence.
surgery, and
Yes.
you know there is no hearing chance for this patient to give by ossiculoplasty because there is ASN loss. So do you do it first stage implant or second stage?
If the cholesteatoma has come, so we'll do for the two-stage surgery only, sir.
Okay, fine.
Yes, sir.
Thank you.
Thank you, sir.
So your study is ambispective, no?
Yes, sir.
You had 8 cases,
Yes, sir.
retrospective.
6 retrospective.
6 retrospective and 2,
Prospective, sir.
and you have shown only one here, no?
Yes, sir.
Yeah. So, but based on these two prospective cases actually, can you say that second surgery after 6 months in a case of cholesteatoma is the adequate time gap to assess the recurrence of the cholesteatoma?
No, sir. In many of the literature, it has been written that cholesteatoma can come back even after 12 months as well, sir.
So, did you address the eustachian tube in your cases? As because you have not mentioned anything about it actually.
Eustachian tube, sir.
Eustachian tube actually. Function of the eustachian tube in a case of subtotal petrosectomy.
In subtotal petrosectomy, we will obliterate the eustachian tube, sir, to avoid further infections, and that would lead to cholesteatoma formation in the future.
Okay.
Yes. Thank you, sir.
Any comment from the audience? I would like to request Guttu sir, please come on the stage to give her the certificate.
I think she has said that diffusion weighted.
I think if it is at all, if it is to be staged, I don't know, I don't have any experience on that, but from the theoretical point of view, I think it is better, it should be staged after 2 years.
If I am allowed to comment, because obviously I am a judge, but I think as far as CI is concerned, the newer generation CIs, we can MRI them very efficiently, up to 3 Tesla. So we will have problem with the older generation for MRI, but with the newer generation implants, I think by next 2-3 years, all the CI will be 3 Tesla compatible. So that problem will be resolved, I think.
Again,
I
if
think
it
we'll
is
proceed to the
1.5
next
Tesla
case.
compatible, now it can be done. Because it is easier to pick up in 1.5 Tesla also.
Shall we close?
Sir,
Okay, you can
I
answer one
So,
question.
in case we go for MRI, the patient should be properly counseled that due to MRI, the polarity reversal may also occur of the magnet. There are few implants in which the magnet can be removed, and MRI can be done, and the magnet is kept in place. So, they all have that socket.
Thank you, thank you. We proceed to the next case after the felicitation.
So thank you everyone for the valuable inputs. Our next presenter is Dr. Tanisha Chopane from National Medical College. Her topic is nasal polyposis in a case of cystic fibrosis.
So good afternoon everyone, this is Tanisha Chopane. Today I am going to present a case report on nasal polyposis in cystic fibrosis. This is one of the cases I'll never be able to forget in my life because right from admitting this patient to proving him positive for cystic fibrosis and getting him operated was a challenge. So talking about the taboo of cystic fibrosis, in medieval Europe it was believed that the children with cystic fibrosis were cursed by witches and are doomed to die. So there was a famous folklore that said, "Woe to the child who tastes salty from kiss on the brow, for he is cursed and soon will die." It was not until 1949, Lowy et al. Postulated that cystic fibrosis must be a genetic defect from autosomal recessive pattern of inheritance. Talking about the patient, we had a 23-year-old male patient who has a history of recurrent episodes of nasal obstruction and nasal discharge since childhood and difficulty in breathing since childhood. We also investigated about the past history and came to know that this patient had history of repeated hospital admission for shortness of breath since childhood. Also, this patient had history of low birth weight, prematurity, failure to thrive, growth retardation, as well as history of recurrent episodes of tonsillitis. Also, this patient had recurrent episodes of pneumonia not responding to medication. So we can clearly make out that this patient had repeated episodes of upper as well as lower respiratory tract infections since childhood. Talking about the personal history, the diet of this patient was mixed. The appetite was decreased. The bowel and bladder habits were irregular. The patient complained that he felt constipated most of the times and didn't feel like eating. Also, this patient had history of stenoria. Along with this, the patient had sleep disturbance, obviously because of the nasal obstruction and difficulty in breathing. Moving on to the general examination, the patient was conscious, coherent, cooperative, but the patient had retarded build with short stature and dull look. The only positive finding we could get in systemic examination was the presence of bilateral V's. Now moving on to the ENT examination of nose, we found out that the facial symmetry was present, but then there was a broadening of nose. There was increase in the intercanthal distance, hence hypertelorism. The skin over the nose was normal, the vestibule was normal, external nares consisted of thick tenacious mucoid discharge in bilateral nasal cavity. Talking about the anterior rhinoscopy, we saw that there was mild deviation of septum to the left, but also there was presence of grayish, grape-like polypoidal tissue in bilateral nasal cavity. We then moved further ahead with the probing of this mass. We found out that there was no attachment with the septum, but there was presence of attachment to the lateral wall. The 360 degree of probing could not be done in this patient. Also, this mass did not bleed on touch. On posterior rhinoscopy, we found out that there was presence of polypoidal mass in the nasopharynx which extended down to the oropharynx. Further, talking about the paranasal sinuses, there was presence of tenderness in the frontal, anterior ethmoidal as well as maxillary sinuses. Talking about the functional test, the sense of smell was absent. The cold spatula test showed absence of misting in bilateral nasal cavity. The cotton wool test showed the absent movement of fibers in bilateral nasal cavity. Now, as I told earlier, in oral cavity and oropharynx, there was presence of mass in the nasopharynx, which was extending down to the oropharynx. As far as bilateral ear is concerned, in direct laryngoscopy and neck, there were no significant findings. Then we prepared this patient for the diagnostic nasal endoscopy and found out that there was presence of polypoidal tissue in whole extent of the nasal cavity, and we found out that there was the origin of this polypoidal tissue was from maxillary ostium. We further did radiological investigation of this patient and found out that there was excessive mucosal thickening in bilateral maxillary sinuses and no aeration. There was presence of soft tissue density in bilateral nasal cavity, hence we could not differentiate this mass from the inferior turbinate. Also, this patient had pansinusitis. There was involvement of anterior ethmoids, posterior ethmoids as well as sphenoid sinus. This is the HRCT thorax image of the same patient. We can see that the patient had bilateral bronchiectasis. So this was the stage we stamped that yes, this patient has chronic rhinosinusitis along with nasal polyposis. But then what about the symptoms this patient had since childhood? What about the digestive features that this patient had, like the decreased appetite? This patient had a history of sidoria. So we planned to do a sweat chloride test in this patient, and we found out that the values of sweat chloride were above the normal values. We repeated this test again and then found out the values still came higher. We actually also did a genotyping in this patient, but we found out that the F508 deletion, which is the most common mutation of cystic fibrosis, was negative. But we need to keep the point in our mind that sweat chloride test is highly specific for cystic fibrosis, and also that CFTR gene has 330 mutation variants, and every mutation cannot be proved. So on the basis of sweat chloride test itself, we can stamp this patient as having cystic fibrosis. Talking about the management of cystic fibrosis is very vast. As far as nasal polyposis is concerned, like in every case of chronic rhinosinusitis along with nasal polyposis, we started this patient on conservative management with nasal steroid sprays, decongestants, antihistaminics, and saline irrigation. Along with this, we gave this patient a short course of oral corticosteroids in dose of 0.5 milligram per kg. We gave this patient antibiotics for the treatment of chronic rhinosinusitis, obviously. Then after this, after the course of conservative management, then when we saw that the patient's symptoms were not relieving, we have to put this patient for general anesthesia OT. We had to take like the complete chest physician clearance of this patient. Along with that, we have to put this patient on the nebulization. We had to put this patient on antibiotics for 2 weeks. Along with that, we had to start this patient on chest physiotherapy. After that, we got the anesthetic clearance of this patient, and then we posted this patient for a full house FES under GA. As far as cystic fibrosis is concerned, we have the definitive management is gene transfer, which does not happen in India. The other management being using CFTR cochlea modulators, then we have lung transplant in these patients. Talking about the HP report was suggestive of inflammatory sinonasal polyposis. These were the post-op photos 2 months after the patient was operated. The sinus cavities were absolutely clear. There were presence of the secretions that we suctioned out. There was no edema, crusting, or scarring as such. Talking about the discussion, cystic fibrosis is an autosomal recessive condition. It is because of mutation of gene on chromosome number 7, the gene being CFTR gene. This gene acts as an anionic channel over the epithelial surface, luminal surface of the epithelial cells, and hence regulates the mucociliary transport. So because in cystic fibrosis, this mucociliary transport is hampered, there's collection of these secretions all over in the sinuses, whether that means small or medium-sized airways. So the most common mutation here is F508 deletion. Talking about conclusion, good management of lung disease in the patient with cystic fibrosis should aim to maintain unaffected and functional upper airways. An annual routine nasal endoscopy should be done in this patient even if the nasal symptoms are absent. These were the references. Thank you.
Thank you, Dr. Tanisha. It was a nice presentation. Actually, did you inquire about his biological parents' genes? Did you do?
Yes, sir, we did about that, but there was like no significant history in his parents. Absolutely no.
Do you
history.
think any one or both of them should have this CFTR like that?
Not necessary, sir.
Not
this
necessary.
can come in the child itself.
After just surgery, did you just ask the parents or the patient to do something? I mean, some precautionary measures to not to get, again, polyp.
Cystic fibrosis is a disease. This will recur again and again. So basically, post-op, we had to keep this patient in situ for observation. Also, while discharging the patient, we taught properly how to do the nasal irrigation of this patient, because it is said that the post-nasal discharge that the patient has also consists of the bacteria like staph and pseudomonas, which can also harbor in the lungs and hence cause pneumonia. So we put this patient like post-operative after the discharge on a course of macrolides along with the nasal irrigation, along with some corticosteroid sprays. Yeah.
Can you name one or two, CFTR modulator?
Yeah. So it is according to the genotype. If it is said that it is G551D mutation, the ivacaftor works very good. If we are considering the F508 deletion, which is most common, there is a triple combination therapy of lumacaftor, elexacaftor along with tezacaftor, which works good in these patients.
Thank you. Very nice paper. Quite eye-opening for us.
Thank you, sir.
Any role of topical antibiotic instillation in this category of subset of patients?
So it is very...
it's not available in our country, but just for knowledge.
We basically, for our patient, we didn't give topical antibiotics as such, but we did give topical steroid sprays. But it is also controversial because the polyposis in CFTR, it is neutrophilic mediated. Normally, the polyposis that everyone has is eosinophilic mediated. So the corticosteroids also does not work. But it is said that because corticosteroid hampers the exacerbation of the lung diseases, we put this patient on the corticosteroids.
That is why I think there is emerging evidence that mupirocin rinses are being tried, and probably this may come out to be one of the options in the post-operative period, because steroid does not work very well in this patient.
In these patients, yeah.
So from just this discussion, what is clear that polyps in cystic fibrosis are of neutrophilic in origin, mostly.
Yes, sir. Yes, sir.
What does it indicate? It indicates that there is some
inflammatory process, definitely, but it is neutrophil mediated.
Mostly neutrophilic, caused by some organism like Pseudomonas or some sorts of
Staphylococcus and Pseudomonas.
some sorts of mostly biofilm infections.
Biofilm infection, yeah.
So considering this actually, why this polyp appears in a case of cystic fibrosis?
So okay.
So in cystic fibrosis, we know that there is colonization of bacteria, mainly the staph as well as Pseudomonas bacteria. So these bacteria, they go into the sinuses and they are responsible to colonize the sinuses. Now these bacteria has certain enzymes like homolysine as well as phenazine. What these enzymes do basically, they decrease the ciliary beating frequency that we have in our nasal sinuses. So because of this, there is a stasis of mucus. So when there is a stasis of mucus, there is also increase in the PaCO2 levels.
So your treatment should aim at clearing those stasis secretions.
Yeah.
That means first treatment is nasal irrigations.
Nasal irrigation, yeah.
Next is antibiotics, either in the systemic or in the local form actually.
Yeah.
The role of corticosteroid is not
It's very controversial in this case.
that clear here
Clear.
actually.
Yeah.
Now keeping apart that pulmonary signs and symptoms, the patient is of 24 years age. Yeah. Getting the ENT related signs and symptoms, what made you think of to go for the sweat chloride test?
Okay,
Why
so-
you are going for this test
Yes,
actually?
sir. So first of all, the patient, the most common cause of morbidity and mortality in the case of cystic fibrosis are the respiratory symptoms, yes. The patient came to us with the symptoms of nasal obstruction as well as nasal discharge. But also, the patient had a history of respiratory illness since childhood. The patient was on treatment from bronchial asthma since childhood, but the patient was not
No,
relieved.
make it little bit simplified actually.
Yeah.
What is the common age of appearance of nasal polyps?
So it's usually 8 to 9 years after bronchial asthma.
Nasal polyps, the common age of presentation.
Sir, 20 to 40s.
No, it is mostly around 40 or fifth decade. When you are getting on young person,
Yeah.
around 20s, it is the dictum. You should think of cystic fibrosis. That is a very simplified
Yeah.
question. Okay, thank you.
Thank you, sir. So also in the Western literature, routine when the newborn screening for cystic fibrosis is done,
Exactly.
we don't
exactly,
do that.
Exactly.
Yeah.
That's why just we want to know,
Yeah.
because we do not practice regularly, how you are doing this sweat salt test.
Yeah, so actually it was very difficult. There are very less institutions for the sweat chloride test and the genotyping. We did the sweat chloride test from the Institute of Child Health. Also, the single test is not confirmatory. We have to repeat that test. And to start the CFTR modulators, as I told that we started according to the mutations. Okay, how we did that? Okay, so we basically take a particular part of the skin and we put pilocarpine in that area, because of which sweating happens, and that sweat is collected. So on the basis of that amount of sweat, we calculate the sweat chloride in this patient.
Thank you.
May I request Professor Barin Kumar Rai Chaudhary to kindly hand over the certificate to Dr. Tanisha. Our next speaker is Dr. Rupsha Shaha. She will speak on childhood deafness and enigma.
You are actually presenting one single case, isn't it? And cystic fibrosis, it is proved. But have you proved that this polyp is due to cystic fibrosis? It can be associated with the other. As you said,
Yeah.
it is cystic fibrosis is of neutrophilic, and others are eosinophilic. So have you tested, and have you, I was thinking as if you were speaking theoretically, without doing
So actually the
anything.
HP report of this patient that we did,
Why it is not simple polyp, allergic polyp?
so again, the histopathological examination of this patient, the polyp that was done, we told specifically to because we knew that it was cystic polyposis, we asked them to know about the neutrophils in that polyp, and that did mention that it was present there.
That is proved
Yeah,
histopathologically.
yeah.
Awesome. Thank you.
Thank you.
Dr. Rupsha will speak on childhood deafness and enigma.
Very good afternoon to all the delegates present in the hall. I am Dr. Rupsha Shaha, and I would like to present on childhood deafness and enigma. Now the question is, why is this an enigma? I would like to come to the answer, but before it, I would brief about the causes of childhood deafness. They are broadly classified into prenatal, perinatal, and postnatal causes. The prenatal causes being genetic and non-genetic ones. Perinatal causes including anoxia, hypoxia at birth, prematurity, birth injuries, neonatal jaundice, neonatal meningitis, and postnatal ones, including various viral infections, chronic otitis media with effusion, ototoxic drugs, mechanical or noise-induced trauma, whatever it may be, neoplasms, and so on. Now, how to approach a deaf child? First, as in all other cases, we start with clinical history and clinical examination, emphasizing on points like failing to develop speech at 1 to 2 years of age, delayed developmental milestones, chronic stigmata, syndromic stigmata, etc. The investigations like objective audiological tests, which include electrophysiological ones like BERA, SERA, otoacoustic emission, electrocochleography, impedance audiometry, and last but not the least, ASSR. And amongst the additional investigation comes complete blood count, thyroid function tests, serology, some immunological tests, renal USG, chromosomal analysis, and the list is kind of never ending. Now I'd like to come to the case history. It was that of an 8-year-old female child presenting with reduced hearing, delayed development of speech, unable to gain weight and height in accordance with age, dry skin, constipation, etc. On examination, she had microcephaly, wide separated eyes with broad nose and flattened bridge. Her skin appeared dry, cold, and clammy. Bilateral tympanic membranes were within normal limits. There was no atresia of the external auditory canal, or no branchial cleft cysts were noted. Anterior and posterior rhinoscopy, oral cavity, oropharynx, and laryngopharyngeal examination were also within normal limit. Her central nervous system examination, in particular among all other systemic examinations, showed that the patient was conscious, alert, playful, oriented to time, place, and person. She had borderline intellectual disability with an IQ of 73. Her speech and language were apparently within normal limits. Cranial sensory nerve examinations were within normal limits as well. This slide shows the pure tone audiometry of the child, which shows that she had bilateral mild sensorineural hearing loss bilaterally, and her transient evoked otoacoustic emission came out to be refer bilaterally, which indicated some pathology in the outer hair cells of the cochlea. Her BERA examinations showed peak 5 at around 40 to 50 decibel. There was and there was some kind of interwave latency, indicating mild to moderate degree of sensory neural hearing loss bilaterally. This slide shows the anthropometry of the child, comparing her weight, height, and all other parameters with respect to another child of similar age. Her parameters came to be less than 3rd percentile of the expected values. Among the other examinations, it was seen that her thyroid stimulating hormone profile was exceedingly high. It came out to be 273 milli-international units per ml with with some kind of low free T4 levels as well. By default, the next investigation done was USG neck, which stunningly showed no visualization of thyroid gland. Her iodine 123 radionuclide scan was done, but the reports are still pending. Serum thyroglobulin, however, came to be within normal limits. To reconfirm, a repeat USG neck was done, which showed the presence of small thyroid tissue in the designated site for thyroid gland. Thus, the diagnosis came out to be sensory neural hearing loss in a case of hypothyroidism, hypoplastic thyroid gland that is, presenting with short stature and delayed developmental milestones. She was treated with thyroxine supplementation, 100 micrograms per day. This chart shows the dose to be treated, the patients to be treated with as per age of the child in cases of hypothyroidism. The FT4 and TSH assessment was done in case of the patient every 2 weeks for a period of 4 weeks after the thyroxine supplementation was started, and the levels reached within normal range by the end of first month of treatment. The patient was reassessed for hearing loss after 3 months and then after 6 months, but unfortunately no improvement could be noted. She was thus sent for trial of digital hearing aid thereafter. Now, to discuss the case, I would like to emphasize again on the fact that congenital hypothyroidism is an endocrine disease which is commonly found in newborns. Almost 1 in every 2,000 or 4,000 newborns are diagnosed with congenital hypothyroidism. It is known that thyroxine is essential for development since intrauterine life. Children with congenital hypothyroidism can develop hearing problems as thyroid hormones are crucial for the auditory pathway development and maturation. It takes part in the maturation and development of both the cochlear and the retrocochlear pathways. Thus, in cases of low free T4, the most common otorhinolaryngological manifestation of congenital and acquired hypothyroidism comes out to be hearing loss. Sensory deprivations, especially in hearing disorders at early ages of development, can impair language skills, behavioral, cognitive, social, and psychosocial development. Thus, along with considering the regular causes of newborn and childhood sensorineural hearing loss, which I already mentioned earlier, ruling out hypothyroidism is a must, as if detected early, it is reversible. This is the follow-up protocol which we already followed, and it had also been mentioned in Nelson. Thus, the take-home message from here is that thyroid stimulating hormone and free T4 screening should be a part and parcel of newborn and children presenting with sensorineural hearing loss. These are few of my references. Thank you for your patient listening.
Thank you, Dr. Shah. It was a good thing. I would just like to ask you one thing. How do you counsel the would-be mothers not to give birth to some child who is going to have some hearing impairment? Number one. And number two, in this case, what will be your line of management? If you would have got this patient in your follow-up, OPD, is it too good? How do you counsel the would-be mothers?
So for the would-be mothers, in case of sensorineural hearing, if we suspect any kind of cause, any syndromic or non-syndromic cause which may lead to hearing loss, then we can positively counsel the mother only, because at present there are n number of possibilities and managements and like bone anchored hearing aids, cochlear implants and everything by which the patient can hear in future after birth, and if detected early, then there are many modalities by which the patient can lead a normal life, almost normal life. So I think that positive counseling will be enough. There will be no need to counsel the patient negatively or to not plan the child or anything. And in this case, unfortunately, we received the patient quite late. The child, when she came to our outpatient department, it was a referred case basically from pediatric department. She was 8 years old. Almost her whole developmental process has reached a peak. So if she would have come earlier and we could or the pediatrics department could start the thyroxine supplementation earlier, her improvement of hearing, there could have been a better improvement in hearing, which we could not receive here. Even after treatment in thyroxine, there was no significant improvement.
Okay, well. Just another question. Can you name the full form of TORCH? Just the disease, because I mentioned.
Yes,
TORCH.
Yes, there will be toxoplasmosis. O for others, R for is rubella. T for toxoplasmosis. O for yes.
Never mind. Just one question. with this new look into the thing, have you incorporated the TSH estimation in all children in your hospital who comes to with a history of hearing loss or any neonatal screening being done?
Yes, sir.
Because does this study or case open eyes and add anything to our medical judgment?
Yes, sir. As far as in my department and my hospital it is concerned, in our outpatient department we receive loads of children who come for hearing assessment. So in case we receive TOE refer or BERA with sensorineural hearing loss, we try to conduct the routine blood investigations at least, if not the immunological examinations and all, but routine complete blood count and thyroid profile we try to conduct in every patient.
Just considering this particular case actually,
Yes, sir.
you had acoustic emissions and audiometry.
Yes, sir.
OAE was passed in both the cases.
No, it was refer only.
Refer in both the cases. So at what age you did it?
She presented at 8 years only. So we did all the investigations possible. We did her
You did audiometry
I
and
did
also
audiometry, tympanometry also. We did
at the same time OAE.
BERA, everything.
And you mentioned that OAE is a electrophysiological test. I am little bit confused about that. Whether OAE is a electrophysiological test or not. Just I don't know actually. But what is the neonatal screening test actually? Talking about this thing actually. Before releasing the child from the institute actually. This is our national guideline.
Yes.
You have to go for OAE, you have to go for TSH assessment actually. That is the main theme of this subject actually.
Yes, yes.
That's the take home message actually.
Yes.
That's okay, thank you.
Thank you.
Thank you, sir.
Thank you, Rupsha. May I request Professor Shantanu Banerjee to kindly hand over the certificate to Rupsha.
Wait. এই দাঁড়াও ইয়ে কোথায় ক্যামেরাম্যান কোথায়
Sir,
এদিকে এদিকে স্যার ছবি তুলবে
our next speaker is Dr. Ayan Bishwas. He will speak on neutrophil to lymphocyte ratio and its association with survival outcomes in head and neck cancer patients.
Good afternoon, the respected judges, teachers, and my fellow colleagues. My name is Dr. Ayan Bishwas. Today my topic of presentation is neutrophil to lymphocyte ratio and its association with survival outcomes among patients with head and neck cancer. So what is NLR? NLR is neutrophil to lymphocyte ratio, which is an important biomarker which can be used as a prognostic factor in head and neck cancer patients. NLR provides us with a convenient and minimally invasive method to assess the prognostic factor in head and neck cancers, proving itself as a significant prognostic and diagnostic method in the assessment of the head and neck cancer patients. Tumors has shown us that it releases cytokines which prompting the bone marrow to release. The objectives of my study is to evaluate neutrophil to lymphocyte ratio as a potential prognostic factor in head and neck cancer patients and also as an indicator for survival outcome in head and neck cancer patients. My study setting is in the Department of Otorhinolaryngology at a tertiary care hospital in Kolkata. It is an ongoing prospective observational study. My study period is started from December 23 till present. Sample size I have taken is 135 patients with primary head and neck cancer. NLR was obtained from routine complete blood counts with differentiation. Other variables included age, gender, primary cancer site, and cancer staging based on the American Joint Committee on Cancer 8th edition. In my inclusion criteria includes primary head and neck mucosal malignancies of various subtypes like nasopharynx, oropharynx, hypopharynx, oral cavity, larynx, nose and paranasal sinuses. other head and neck malignancies like thyroid and parotid neoplasm. I have taken ages from 15 years to 70 years with primary head and neck cancer. Exclusion criteria are history of neoadjuvant therapy, neoadjuvant chemotherapy or radiotherapy, history of prior therapeutic interventions, lymphoreticular malignancy, pediatric age group patients with soft tissue malignancies, acute presentation with inflammatory condition like neck abscesses, coexisting synchronous or metachronous malignancies, cutaneous malignancies like squamous cell carcinoma, basal cell carcinoma and melanoma, prior history of non-head and neck malignancy. This table shows us the number of patients with various head and neck cancer with their staging. This is a pie diagram, shows the various head and neck cancers and their prevalences. 15% nose carcinoma, 19% nasopharyngeal carcinoma, 14% oropharyngeal carcinoma, 19% hypopharyngeal carcinoma, 22% laryngeal carcinoma, and 11% of oral cavity carcinoma. This is a statistical diagram shows us the number of patients suffering from hypopharyngeal carcinoma and the site of origin. As we all can see, pyriform sinus has got the maximum number of patients, followed by postpharyngeal wall carcinoma, and at last post-cricoid region carcinomas. This histogram shows us the number of patients with laryngeal carcinoma and the site of origin. Glottic carcinoma has the maximum number of patients, followed by subglottic carcinoma, and at last subglottic carcinoma has the least number of patients. This representation shows us the number of patients of nose and nose and paranasal sinus carcinoma and the site of origin. Maxillary carcinoma has the majority of the patients, followed by nasal cavity carcinoma, and ethmoidal carcinoma has the rarest one. This statistical analysis shows us the oral cavity carcinoma patients and the site of the origin. Buccal carcinoma has the maximum number of patients, followed by gingival sulcus carcinoma, then tongue carcinoma, and the other oral cavity carcinomas. The table shown on the top of my screen represents the various stages and their respective mean value of NLR. The representation shown on the bottom of the screen shows that while we go from stage 1 to stage 4, the mean NLR value has also increases significantly. Results: among these 135 patients, 20 patients presented with nose and PNS carcinomas, 25 patients with nasopharyngeal carcinoma, 19 patients with oropharyngeal carcinoma, 26 patients with hypopharyngeal carcinoma, 30 patients with laryngeal carcinoma, and 15 patients with oral cavity carcinoma. Mean value of NLR increases with higher staging. Patients with higher NLR values have more aggressive cancer and worse treatment outcome. Discussion: immunosuppressive neutrophils have been implicated in tumorigenesis and tumor progression by remodeling the tumor microenvironment, increasing tumor cell survival by facilitating angiogenesis and protecting tumor cells from the cytotoxic activity of lymphocytes. Tumor-associated neutrophils facilitate tumor growth by immunoediting, increasing proteases to facilitate tumor invasion, and activating neutrophil extracellular traps to enhance tumor adhesion and metastasis. Reduction of such tumor-associated neutrophils was shown to inhibit tumor growth, reduce immunosuppression in tumor microenvironment, and improve CD8+ cytotoxic T lymphocytes. The limitations of my studies is this: it is an ongoing study and it has been conducted within a brief period of time. So the collected data available is of small group of patients suffering from head and neck carcinoma. Neutrophil lymphocyte ratio can be elevated due to various factors besides cancer, such as infection or inflammation. Neutrophil lymphocyte ratio may not be elevated, may not be equally accurate for all stages of types of head and neck cancer. More research is needed to determine the best way to use the NLR in clinical decision making for head and neck cancer patients. Thus, conclusion of my study is NLR is a simple blood test that can be used as a prognostic marker in head and neck cancer, and elevated NLR has been associated with higher complications in patients with head and neck cancer. NLR may be a helpful tool for identifying patients at higher risk of complication or death. These are my references. Thank you.
Thank you, Dr. Biswas. This is solely based on NLR ratio, NL ratio. Have you gone to the, lab to see the slides yourself, or just relied upon the pathology report?
I have collected the data from the patients admitted under our care, under our department, and we have sent the CVC of every patient and collected the data from there only.
Oh, you have not seen the slides, just you have not. How do a neutrophil look? How do a neutrophil look? Neutrophil. How does it look actually? Is it cell? Is it neutrophil?
Sir, several loops, sir.
Loops.
Yes, sir.
Is it membranous or non-membranous?
Membranous, sir.
Membranous. And then inside the membrane, what is there?
So there will be granulation, sir.
Any nucleus or not?
Yes, sir, nucleus, sir. It is present in there.
How many nucleus? Is it round, or is it like dumbbell shaped, or is three type of dumbbell like that? You have not seen. Have you attended your physiology class?
Yes, sir.
Okay. Now you are solely dependent on NLR ratio.
Yes,
Before that, being a doctor, an ENT surgeon, what is the main prognostic criteria seeing a tumor? A patient asks you, yes, sir, how my patient will live, or what is the prognosis like that. What you will say and what you will look?
So the extent of the disease.
Extent.
Yes, sir.
Okay.
And sir, the comorbidities present in this patient.
The tumor itself, its size, its extension, is there any metastasis, is there any nodal involvement? This is the as a surgeon. Then you will go for NLR. And another thing, you have not mentioned which type of carcinoma it is. Is it squamous cell carcinoma or adenocarcinoma or some other carcinomas? You are dealing with which type of carcinoma? Because NLR is very sensitive of this type of carcinoma. I am not going to tell you the carcinoma, okay?
So it's a good study, but you need some more statistical analysis. Number one is the multivariate analysis. Do you know what is that? You have divided head neck region into 3-4 regions actually. So region specific result and their analysis, age specific result and their analysis, gender specific results and their analysis. You can, because it is purely analysis of a statistical data. You have to make it more attractive, you have to go for further analysis actually. No, not limitations. You can present it here very well. Among the laryngeal cancers, this is the thing. Along the hypopharyngeal cancer, this is the thing. Along the oral cancer, this is the thing. And you have not been, though you have included the thyroid and parathyroid malignancies in your study, but you have not mentioned their ratios in your bar diagram, I think, actually. Yes. These are the weaknesses of your presentation, but it's a good thing, actually. Good idea. Thank you very much.
Thank you very much. If anyone has any personal experience of using this kind of stratification system, I would invite comment from them, but not questions. If none, then we can proceed.
Thank you, Dr. Ayan. May I request Professor A.M. Shaha to kindly give the certificate to Ayan. Our next speaker is Dr. Arundhati Mukherjee. She will speak on left maxilla odontogenic myxoma, a case report.
Good afternoon, honorable judges and my seniors and colleagues all present here. So today I will be presenting on an unusual case of maxillary swelling. So, 30-year-old female presented with a left-sided painful cheek and ipsilateral hard palate swelling for the past 1 year. The swelling was insidious in onset, associated with dull throbbing facial pain, and the left-sided hard palate swelling was painless for the same duration, insidious in onset and gradually progressive. However, there was also associated history of left nasal obstruction with left nasal discharge, which was mucoid but not blood-stained. There was no history of dysphagia or teeth loosening. In the relevant negative history, there was no history of postnasal drip, hyposmia, anosmia, trauma, previous facial surgeries, any diplopia, double vision, blurring of vision, painful eye-restricted movements, or recent history of tooth extraction. And the general examination and systemic examination were unremarkable. Coming to the local examination of the face, 5 centimeters into 5 centimeters globular large ill-defined swelling was observed on the left cheek. The sensations were intact, temperature was normal, the skin over the swelling was pinchable. The eye examination revealed a left-sided proptosis and the infraorbital rim was irregular on palpation. The oral cavity examination showed a 4 centimeters into 3 centimeters hard swelling on the left hard palate, which had no eggshell crackling and was non-tender. The neck didn't show any significant palpable cervical lymphadenopathy. The CT scan revealed a large heterogeneously enhancing mass as shown here, involving the left maxillary sinus and on the coronal cuts and serial axial cuts as it can be observed. The differential diagnosis as per my the clinical examination came out to be maxillary sinus malignancy, invasive fungal rhinosinusitis, infected dentigerous dental cyst, and rare benign maxillary tumors. So next, we did a further workup of the patient. We went for a biopsy from the visible part of the hard palate swelling, and it came out to be fibrous collagenous tissue with areas of edema and necrotic bone tissue bits with dense lymphocytic inflammatory infiltrate. However, to confirm our findings further, we went for another endonasal biopsy from the left maxillary sinus antrum, where bits of squamous epithelium, this time with dysplasia, and pseudostratified ciliated columnar epithelium and dense inflammatory infiltrate was seen. To further confirm our findings, we also went again for a Caldwell-Luck approach biopsy, where this time we got a diagnosis of odontogenic myxoma, which showed bland spindle cells arranged haphazardly, abundantly in a bagroid of myxoid tissue, myxoid stroma. So the diagnosis came out to be odontogenic myxoma of the left maxilla. And the treatment that we undertook was left total maxillectomy with orbital floor reconstruction and forehead flap reconstruction under general anesthesia. So the pictures are a Weber-Ferguson incision was given, the cheek flap was elevated and the infraorbital pedicle was identified. Then the maxillectomy osteotomies were done. Then we placed a titanium mesh for the orbital reconstruction. Then the forehead flap was marked. And through the tunnel, we placed the forehead flap. And this is short video showing the entire procedure. So the Weber-Ferguson incision is given. And after the Weber-Ferguson incision was given, we raised the cheek flap and then the infraorbital rim as it was identified, infraorbital pedicle, and then we went for the placement of the palatal and osteotomies, and then with a jiggly saw we excised the mass and the entire maxillectomy specimen. Then we placed the titanium mesh followed by the flap reconstruction right after this. The flap is being marked. So this was the specimen that was delivered. The final histopathology reporting also came out to be as an odontogenic myxoma with bland spindled cells arranged against a background of myxoid stroma. There's the odontogenic focus here. So post-operative pictures of the patient in recovery. We also did a post-operative, this is the post-operative CT scan as well, which shows the titanium mesh in situ and the flap also in situ. So odontogenic myxoma is a benign neoplasia arising from the odontogenic epithelium, and odontogenic tumors comprise less than 1% of all head and neck tumors. So it is a rare case, and it was a locally benign invasive neoplasm. Radiologically, we saw in our CT scan as well, the features were of cortical expansion and perforation, and honeycombing appearance also of the bone was seen. So as per the management protocols, smaller myxomas are usually managed by curettage and close follow-up for next 5 years because it is a notoriously recurrent lesion, and larger lesions require extensive resection with at least of 0.5 centimeter to 1 centimeter margin. And the take-home message, this case was a diagnostic dilemma because clinically it mimicked a neoplastic lesion on presentation. However, its prolonged indolent course didn't positively point towards a malignancy, which we were initially suspecting. Radiologically also it was mimicking a malignancy because of the wide bone destruction as seen in the CT scan. Commonly, commonly this tumor is confused with invasive fungal rhinosinusitis and the rarity of the lesion. So ultimately, the pearls that we learned from this case was a high index of clinical suspicion is required for diagnosing such rare benign tumors of the maxilla, and a definitive histopathological diagnosis is of utmost importance for confirming our findings and for determining the management protocols. And an aggressive management is required for such tumors because leaving any focus of the odontogenic focus will cause a recurrence of the tumor and again another surgery for the patient. Thank you.
Thank you. Very nice case. Very well documented, well reproduced. One small question is, because you had so many DDs like malignancy, invasive fungal sinusitis, so do you think an MRI would have helped you in pointing towards a more pinpointing diagnosis with one or two conditions?
Sir, an MRI would have perhaps given us a better soft tissue delineation of the lesion and nature of the lesion, but for a definitive diagnosis, a histopathological confirmation would have been
I'm not questioning that. What I am saying, for example, if you suspect invasive fungal sinusitis, would an MRI be pointing quite strongly towards an invasive fungal? And if so, what are the features of invasive fungal sinusitis on MRI?
Sir, an MRI would definitely show the better, would confirm our suspicions of invasive fungal rhinosinusitis, because we would be able to appreciate the soft tissue invasion of the bone, and if possible, if the fungal elements we could have appreciated due to the heterodense appearance of the lesion and maybe areas of calcification.
Okay, thanks.
Yeah, Dr. Mukherjee, it was a good question. Before doing the CT or MRI, whatever you say, did you do an OPG? Because you suspected some odontogenic myxoma. Myxoma.
Yes, sir. Patient had gone to the dental. We had given a dental referral for the patient, and an orthopantomogram was done for the patient. However, I don't have the image for it. It's with the maxillofacial surgery department. So I had personally gone and seen the picture, sir. It was showing soap bubble appearance of the tumor.
Soap bubble.
Soap bubble and cortical bone thinning was shown.
Soap bubble is a good, thing. Can you name one, bone tumor which has a soap bubble appearance?
Sir, ameloblastoma.
Osteoclastoma.
Osteoclastoma, giant cell tumor.
Thank you. Soumitra, we would invite any comment from the audience. As I said, if anyone has any comments, very welcome. But comment, no question. Comment koro, please. ওরা ভয় পেয়ে যাবে কমেন্ট কোশ্চেন করলে।
Beautiful narration, but I think MRI will suffice not to go for OBG, because MRI will give you the exact location, site, what we do in PG hospital, SSKM, because we have got head and neck surgery, we have got plenty of cases like you, what you are presenting. We only depend upon MRI, not upon OBG. So MRI would be suffice to have an exact diagnosis of it. Thank you very much. Beautiful narration.
Thank you so much.
sir.
Thank you.
Excellent presentation, and really you have described it. So one thing is that that titanium plate reconstruction, is it really required? Because it's costly. It costs around 40 to 50,000. Very small one. So in my experience, you can remove the total maxilla, you can remove the total floor of the orbit also. There is no problem with the movement of the orbit. So titanium plates may not be required always, as it's a very costly one, we can avoid it. Thank you.
But if facilities are available, it's if you have the resources, you can always do this.
No, it's really not required. Not required.
Actually, the prosthodontics persons will say the last word actually.
Thank you. May I request Professor Tapun Kanti Hajra sir, to kindly give the certificate to Dr. Arundhati Mukherjee.
Meanwhile, we have an announcement to make
May I
from the official
invite-
announcement from the association AY West Bengal.
Hope you are all enjoying the academic program. Thank you for being here and supporting us and encouraging these young junior ENT surgeons and PGTs. I have one announcement that I invite Dr. Manoj Mukherjee sir, and I request our president Dr. Amitabh Raychaudhuri sir to announce the date of Meet AYWB Con, which will be at Bardhaman Sinclair's on 3rd and 4th of August.
So we are announcing the Midway-Con. Dr. Manoj Mukherjee, under the able leadership of all the seniors and his juniors, is going to conduct the Midway-Con at Sinclair's Bardhaman. Obviously, as we know, Midway-Con is a live surgical event. So we are looking forward to go to Bardhaman, and Manoj is going to tell us what is the plan.
Yeah, this is our request to my respected teachers, my dear seniors, juniors and friends. Please come to Bardhaman. Probably you had that experience in pre-COVID. That was our last assembly before COVID in 2020. That was held in Bardhaman, and that time also we tried our best to make it a successful one. So this time also we should try our best to make it a memorable one. It's never possible without your wholehearted support. So your presence will be highly appreciated. Please do come in Bardhaman. আমাদের ওখানে থাকার এবং আদার অ্যারেঞ্জমেন্টগুলো আমরা চেষ্টা করছি যতটা ভালো এবং যতটা কমফোর্টেবল করা যায়। বর্ধমান কলকাতার মতো জায়গা নয়, বাট স্টিল ইউ ক্যান হ্যাভ আ ভেরি হ্যাঁ
I think আমরা সবাই যাব, উইল এনজয় দি একাডেমিক ফিস্ট।
সবাইকে আহ্বান জানাচ্ছি, সবাই আসবেন কনফারেন্সে।
আর
ওটা থাকবে স্যার, ওটা থাকবে, ওইটা বর্ধমানে থাকবে, একদম বাড়ি মানে বর্ধমানে উইথ জিআই ট্যাগ, ওটা বাড়িতে আসার সময় সবাইকে দেওয়া হবে, সো দ্যাট ইউ ক্যান ক্যারি ইউর সুইট মেমোরিজ টু ইউর হোম। তো এবং আশা করছি সার্জারি যে ওয়ার্কশপটা সেটাও খুব ভালো হবে, আমাদের খুব ভালো সেট আপ আছে। আমরা 3 তারিখে 9টা থেকে শুরু করব, সকাল 9টা থেকে। হ্যাঁ, বাই লেটেস্ট 10টা থেকে শুরু করতেই হবে, কারণ অ্যাটলিস্ট 10 কেসেস আমরা দেখানোর চেষ্টা করবো, অ্যাটলিস্ট 10। এবং মোস্ট প্রবাবলি যা থিম উইল বি হেড নেক। সো প্লিজ কাম।
I think
সবাই আসবেন, হ্যাঁ
I
সব
think
কিছু থাকবে।
what we have decided in
Yeah.
general is that this time we are going to have faculty from our own faculties from the state, own state, who will demonstrate their skills in various surgical. But Manoj being an head and neck surgeon, the main focus is going to be head and neck surgery. But we will also incorporate other things.
Definitely.
So it will be our own workshop, and we will all go in a team and encourage them and enjoy in addition to learn.
Okay, সবাই আসবেন।
Also one more, we are very happy to announce that this time for the clinical meeting, earlier we used to have 6 presentations, sometimes 6 to 8. This time we had 23 submissions for this meeting. And we had to choose, like it's like a lottery system from all colleges, equal distribution. And we have decided, so because we have another 13 papers left, so for the next clinical meeting, which will be held at CMRI, Calcutta Hospital on 29 June, under the host of Dr. Arjun Das Gupta, Dr. Mohan, and Dr. Chiro. So we are going to select the cases from this submission, and we are not going to invite any more for the next one. And it's a very proud feeling that more and more people, so this is a fantastic platform for all of us, that all the juniors, irrespective of college, city, urban, rural, everyone can come and present their work and showcase their work and interact. So let us continue. Long live AY West Bengal.
The thing is, the people, those who are audiences, they have got so many things to ask, to discuss, to advise, so many things. But if you do not do that, this actually, I feel, this is my own opinion, that this is not getting any interaction between the candidate, between the judges, and between the audiences. Audiences will come and sit without saying anything, without asking anything, without just hear and go back. It's not interesting.
Sir.
You keep less cases, rather. You keep not keeping 10 cases, you keep 6 cases, and give the audiences to some time to discuss about it. That will create more impact, and that will create more development of more interactions and knowledge. So, hearing a young person telling and not being able to ask any questions by audiences or learned people here, it is actually my thing is I don't feel comfortable.
Sir, আমি বলছি আমাদের আমরা স্যার আমি যেটা বলছি আমাদের we are trying to strike a balance between trying to accommodate more people, more youngsters to present, and at the same time do justice to the time. কারণ একটা প্রবলেম হয় যে যখন লাস্ট স্পিকার বলবে তখন বিকেল 4:30 হলে আমাদের অডিয়েন্সের 5 জন থাকবে, অনেকেই চলে যেতে বাধ্য হবেন ফর দেয়ার কমিটমেন্টস। সো উই ওয়ান্ট দ্যাট ফুল হাউস শুড বি দেয়ার ওয়েন অল দ্য স্পিকার্স আর প্রেজেন্টিং, অ্যান্ড এট দি এন্ড অফ দ্য থিং all interaction can happen live again. And sir, one more thing, we said that experienced teachers and experienced surgeons can always comment, but question করলে ওরা একটু হয়তো ভয় পেয়ে যাচ্ছে, and it may be reflected on the judges. So এই ব্যালেন্স, আমরা এই ব্যালেন্সটা করার চেষ্টা করছি। স্যার আপনার মতামতটা, সবার মতামতটাই আমরা নেব, এবং প্রত্যেক মিটিংয়েই আমাদের কেমিস্ট্রি অফ দ্য মিটিং উইল চেঞ্জ। একটু আমরা সব রকম ইনকর্পোরেট করার চেষ্টা করছি। এখন 23 জন ছেলে মেয়ে যদি জমা দিয়ে থাকে, if we have to do justice, monthly clinical meeting ছাড়াও we have now 2 peripheral workshops we decided in the meeting we have started. So mid-Icon, AOICON, peripheral workshops, 2 live surgery workshop throughout the year, plus monthly clinical meeting. এর বেশি তো আমরা আর বাড়াতে পারছি না। সো সবাইকে প্ল্যাটফর্ম দিতে হলে এইটা করছি, কিন্তু স্যার আপনার ইয়েটা আমরা রাখলাম। নেক্সট টাইম আমরা আবার আবেদন করব সবাইকে যে মানে উই অলওয়েজ সেড ইউ প্লিজ কমেন্ট, কিন্তু বেশি কোয়েশ্চেন করলে একটু লেংদেন হয়ে যায়।
কমেন্ট ইনভাইট করছি তো,
কমেন্ট তো নিচ্ছিস
সেটা এর পরেও।
সো ফ্রম দ্য নেক্সট আই থিঙ্ক দ্যাটস এ ভেরি ভ্যালিড পয়েন্ট। স্যার আপনি বলুন, স্যার কিছু বলছেন, মানে ইট ইজ ইম্পর্টেন্ট, কারণ এত কষ্ট করে এভরিওয়ান স্পেয়ার্স দেয়ার টাইম অ্যান্ড ইউ শুড ফিল দ্যাট ইউ আর কন্ট্রিবিউট।
আচ্ছা, আমাদের আরো প্রেজেন্টেশন আছে।
So next time we'll try to do that system that all the presenters will be done, they'll be judged, and then they can all come to the dais and they can be grilled.
আচ্ছা, যদি কেউ বর্ধমানের জন্য রেজিস্ট্রেশন করতে চান তাহলে আমাদের মানে এখানে বিল বই।
May I now request Dr. Ayesha Shirin K to come on days. She will speak on a comparative study of variations in tympanometry on post-operative tympanoplasty with or without cortical mastoidectomy.
A very good afternoon to all. I am Dr. Ayesha Shirin. Today I am presenting the topic, a comparative study of variation in tympanometry on post-operative tympanoplasty with or without cortical mastoidectomy. It might sound a little confusing. So the objectives of the study was to compare the tympanometric findings in inactive mucosal chronic otitis media patients who underwent type 1 tympanoplasty versus those who underwent type 1 tympanoplasty with cortical mastoidectomy. And we also had a secondary objective to assess the efficacy of tympanometry in evaluating the middle ear function in chronic otitis media patients. Now, why did we choose this study? It was because the role of cortical mastoidectomy in inactive mucosal COM is still controversial, although multiple studies have been conducted in the same topic, which gave inconclusive evidence. It is the studies were so much that the systemic reviews were conducted on the same topic, and they also suggested the need of further prospective studies which should be large and multicentric. So why did we choose tympanometry in this case is because, as we all know, mastoid air cells are the pressure buffering system of the middle ear, and we wanted to know whether by doing a mastoidectomy, is there any kind of change that is happening in the middle ear function post mastoidectomy? And tympanometry being a very easy and objective test for middle ear function, we choose tympanometry for the assessment. Coming to the review of literature, as I told you earlier, there were many number of case studies which were conducted on the same topic, and in last 20 years out of these topics, only 4 studies were able to find a positive correlation, and cortical mastoidectomy was found to be effective in inactive mucosal COM according to Habib et al., Eliades et al., Sharma et al., and Agarwal et al. Meanwhile, the other people were not, the other 8 studies in last 20 years were not able to find this relation, and they concluded that cortical mastoidectomy is not adding to any extra benefit in case of inactive mucosal COM. It was a prospective cohort study which was done over 2 years in 2022 to 2024, and the adults from 18 to 50 years with central perforation and mild to moderate conductive hearing loss were included in the study, and a dry ear for more than 4 weeks were maintained before the surgery. 102 patients were selected, and out of which 57 patients underwent tympanoplasty, while 45 patients underwent cortical mastoidectomy plus tympanoplasty. A preoperative tympanometry was documented, and also these patients were called up 6 months later for a postoperative tympanometric assessment. The statistical analysis was later on done in SPSS with paired t-test and independent sample t-test. Coming to the result analysis, the demographic data was more comparable to the general population with mean age of 33.5 years with no specific gender preponderance as we see in chronic otitis media. The most common presentation was unilateral discharge with hearing loss in which 91.1% had mild conductive hearing loss. The mean duration of the illness was 9.05 years, with a wide range of 6 months to 27 years of duration. So the median was also taken and it was 7 years. The tympanometric variables of the contralateral normal ear was considered as the standard values for the same for the candidates, because so that the standard same individual can be same individuals, deceased ear and the contralateral ear, both were taken into consideration. So the type of curve was A-type in contralateral normal ear. The canal volume was 1.14, which comes in the normal category. The static compliance was 1.03. The peak middle ear pressure was minus 34 decapascal, and pressure gradient was found to be 1.19 decapascal. Coming to the result analysis, preoperative and postoperative tympanoplasty, it was found that the P-type curve in preoperative cases were changed into A-type in 92.9% cases, and the canal volume reduced from 1.44 to 1.11. Now, why is this reduction, significant reduction in canal volume? Is because the central perforation which was existing has now been closed, and therefore the EAC and the middle ear has now become two different entities, due to which the canal volume has reduced. The statistical compliance also improved due to the tympanoplasty, and it came to be 0.32 ml, and peak middle ear pressure also came more towards the zero. It was initially very high negative, like the mean was minus 369, and it came more towards the zero, that is minus 19 post surgery. The pressure gradient was also found to be increasing to a value of 0.21. While considering the cortical mastoidectomy, a similar kind of trend was observed, and the 93.3% cases attained A-type curve after surgery, and as mentioned earlier, in this case also 1.23 cases, the volume reduced from 1.57 to 1.23. The static compliance also improved in this case also. The peak middle ear pressure more towards zero, and pressure gradient is also improving. Now coming to the actual assessment, that is the postoperative tympanometry in tympanoplasty and cortical mastoidectomy. The type of curve was A-type in both, but as you can see, there is no much difference in tympanoplasty and cortical mastoidectomy. It is 92.9% in tympanoplasty, while it is 93.3 in case of cortical mastoidectomy. While canal volume is also having a minor variation of 1.11 to 1.23. Static compliance is also very much similar. Peak middle ear pressure minus 19 and minus 23. Peak pressure gradient 0.21 and 0.22. It was found in an independent t-test that this difference was statistically not significant. As I told you earlier, the previous studies were mainly for hearing outcome and graft uptake, and none of the studies were done on the middle ear function of the test. And as tympanometry is not done regularly in COM patients, it was very difficult to find a study which assessed middle ear function with tympanometry in literature. The tympanometry of the normal and tympanometry of the deceased were found to be statistically significant, whereas this postoperative tympanometry was not found to be statistically significant. So our conclusion is that cortical mastoidectomy doesn't give any additional benefit in terms of to tympanoplasty in terms of middle ear function. We can't comment on any other things, middle ear function in inactive mucosal COM, but as we can see, there was significant variation. So tympanometry can be a useful tool in assessing the improvement in middle ear function postoperatively. Thank you.
Thank you, Dr. Ayesha. It was a good thing. Was the surgeon same during this 2 years period?
No, sir. It was the limitation
surgical
of
team
the
was
study.
different.
Sir, it was a limitation of the study.
Yeah. And the second thing is, as because there is no significant improvement doing a cortical mastectomy with tympanoplasty.
Yes, sir.
What is the take-home message to the audience, you should say?
Sir,
Because, the cortical mastectomy itself has some hazards.
Yes, sir.
Definitely, and it will be time-consuming because nowadays...
sir, there are other risk of injury to facial nerve and other the bone drilling. Everything is the cortical mastectomy in itself has some demerits when compared to doing a tympanoplasty alone. But the systematic review, as I told you earlier, they are they are still suggesting the need for a more prospective and multicentric and high-scale studies. I agree that the study which I did has found no additional benefit, but I would suggest that more studies, more large-scale studies, probably multicentric studies should be done, and if possible, once in one single center, all the surgery should be done by a single surgeon. In that case, a more valid report may be possible.
Okay.
What was your selection criteria?
So selection criteria, only the patients who had inactive mucosal disease were selected. The inclusion criteria was 18 to 50 years and those with central perforation and mild to moderate hearing loss, conductive hearing loss.
Any other factors did you consider, like status of medulla mucosa?
Yes, sir. We assessed the medulla mucosa was assessed, and it was confirmed that the medulla mucosa was normal.
Thank you.
So how do you select the cases? Who has to go for mastectomy and who?
Sir, it was randomly assigned.
Randomly?
Yes, sir.
Yeah.
There was no. It was it was the surgeon's preference only. It was just a random. That is why it was not equally divided. It was 57 and 45.
Okay. How did you assess that the other year was normal?
Sir, all the basic clinical.
You have considered it.
Yes, sir.
But you have to go for some assessment that year is normal.
So the clinical examination was done, audiometric evaluation, and also tympanometry was done, sir. And to assess the normal medulla mucosa, radiology was also done, sir.
Do you find any role of meningoschlerosis on the opposite ear in assessing your cases?
Myringosclerosis.
Can it be a confounding factor?
Yes, sir, it can be, because healed COM can be, it is possible and it can be a confounding factor, sir.
Since this is our bread and butter, I would invite some pearls of wisdom from senior members.
Hello. You are doing the tympanoplasty as a preoperative procedure in the central perforation mucosal disease, safe type of disease. Is there any medical issue you can solve it with doing the tympanometry prior to the surgery and post-operatively? Can you defend yourself in the court? It's a simple procedure. Can you have this is one of your strong hold that you are doing the right thing. Can it be solved in the court? By your result, you have shown the result to us. Because when you are doing the tympanometry prior to the surgery, preoperatively, the volume of the air volume is become more. And post-operatively, air volume is good. That means it has been perforated. They are not going to the middle and come to the institution tube. This is the one thing. And this is the proof that whatever you have done right thing. That is medically you can stand yourself. That's why every time the central perforation do the tympanometry, so you can have a pre and post-operative comparison, number one. Number two, the mobility you have said, it will be after tympanoplasty, it will be the A-type. Hardly any time, I think the 100 members are also there, you can find the B-type to convert into A-type is hardly. This is it. You have shown the B-type in the perforated ear, and post-operatively it become a A-type.
Is it every cases? And as regards your doing the cortical mastectomy, in my opinion, what I do, if it is sclerotic mastoid and dry for more than 3 months and mucosal disease, and under microscope you can see the middle mucosa is absolutely okay. If it is a cellular mastoid, I always look into the antrum. If it is a sclerotic mastoid, I don't do it. That's this one. Thank you.
ডক্টর বিকি রায়চৌধুরী স্যার কিছু বলবেন? সৌমিত্র ডেকে দাও, ফেলিসিটেশন।
One thing, you see,
May I request?
I don't think that tympanometry has got any relationship with the cortical mastectomy. Whether you will do, as you said, you also have not got any statistical. So it has got nothing to do with that. But you have shown one chart, one slide, where some people are saying that cortical mastectomy is good, it's not good. But that you cannot do that. In some cases where the ear is not drying, almost very regularly having discharges and all those, in that case you will have to go for mastectomy, cortical mastectomy. But the thing is, in majority of the cases, you need not go for that if you do at least proper investigations to exclude any secondary infection anywhere around ear. Say in the adenoids, in the mastoids, or in the pharynx, etc., etc. So proper investigation preoperatively to exclude any focus of infection. If it is not there, and if necessary, you can go for CT scan of the mastoids also to see whether what is the condition of the mastoid, is there any infection or something, some wrong thing is there. Only then you go for cortical mastectomy, then or mastectomy and tympanoplasty. But as you said that we do not do, as you, in the beginning you said that we do not do tympanometry in all cases. Why? You will have to do tympanometry in each and every case, as Dr. Ohen said, Dr. Saha said that medical legal importance is very, you are saying that you have got a perforation, you need an operation. How can you explain that? If the patient goes to the court, how can you prove that you have got a perforation in the ear? And tympanometry is one of the proofs that you had perforation, because the B-type tympanogram is there. So that is very important, and in each and every case of COM, you should go for tympanometry. And always you cannot say that I do not do cortical mastectomy. But in majority cases, I say more than 90% of cases, you need not go for cortical mastectomy in tympanoplasty. That is my opinion.
Thank you, sir. Thank you.
May I now request Dr. Dulal Bose to kindly present the certificate to Dr. Ayesha Shirin.
Meanwhile, may I invite Dr. Kiran Kongal Marak for his for her presentation. Dr. Kiran, please come and get your presentation ready.
Rhinoorbital mucormycosis, opposite ends of the spectrum.
Good afternoon, respected judges and teachers. I'm Dr. Kiran K. Marak. I'll be discussing on the opposite ends of the spectrum of rhinoorbital mucormycosis. We know that mucormycosis is an acute opportunistic infection. It is a rapidly progressive disease, being angioinvasive in nature. It occurs with weak immunological defense mechanisms such as malignancy, leukemia, diabetes mellitus, immunosuppressive therapy, and last but not the least, COVID-19 infection. The route of spread is via inhalation, percutaneous inoculation, and ingestion of spores. We all know the pathogenesis of mucormycosis, how the spores get inhaled, deposited in the nasal turbinates, gets inoculated into the tissue with penetrating trauma, and then it gets impaired by glucocorticoids, neutropenia, hyperglycemia, and iron overload, whereby causing angioinvasive growth with hemorrhage, thrombosis, and necrosis, causing dissemination. During the second wave of COVID-19 pandemic in 2021, there was a sudden increase in the number of mucormycosis, with 83.2% of patients having a history of COVID-19 infection, and out of that, 41.6% had symptoms within 1 month of infection onset. The most common it was in patients with diabetes mellitus in 75.8% of cases, and commonest clinical presentation being rhino-orbital mucormycosis. In the month of May 2021, a patient, 41-year-old male, got referred from periphery with a complaint of pain and swelling over the left eye and progressive loss of vision for 1 month. There was ulceration of left side of face for 1 week and fever for 2 days. He was a known case of type 2 diabetes mellitus, and he had been COVID RT-PCR positive 2 weeks back before the onset of symptoms. On examination, there was a bulge in the bridge of nose and left cheek with ulceration and blackish discoloration of skin. On anterior rhinoscopy, there was necrotic tissue seen in the left nasal cavity. The patient had numbness in the left side of face with proptosis and absence of perception of light and absence of eye movements in the left side. On diagnostic nasal endoscopy, black necrotic tissue was seen in the nasal cavity. Non-contrast computed tomography of nose and paranasal sinuses were done, in which there was a collection in the left maxillary and ethmoid sinus. Magnetic resonance imaging of orbit, nose and paranasal sinuses, they showed a classical involvement of left maxillary and ethmoid sinuses, left orbital apex and extraocular muscles, showing a classical symptoms of mucormycosis, in which the T2 showed hyperintense opacity with loss of fat plane. Diagnostic nasal endoscopy with biopsy was done, and it was sent for histopathological examination and fungal staining, which showed broad aseptate ribbon-like hyphae with wide angle branching at irregular intervals. The patient had underwent left partial maxillectomy with left orbital exenteration with debridement of necrotic tissue in collaboration with the ophthalmologist. The patient then received injection amphotericin B for 4 weeks, followed by tablet posaconazole, and after 6 weeks, the patient had underwent redebridement of nose and paranasal sinus, and then there was a continuation of injection amphotericin B followed by tablet posaconazole. In the month of August 2023, a patient, 48-year-old male, complained of right eye swelling and gradual loss of vision for 6 months. There was intermittent epistaxis and occasional nasal obstruction in the right side for the last 3 months. The patient had no history of COVID-19 infection and no history of diabetes mellitus. On examination, there was a bulge in the bridge of nose and right cheek. There was no mass lesion seen in anterior rhinoscopy, and nasal function tests were found to be normal. There was no maxillary and facial tenderness. Proptosis and restricted movement of eye was seen, with the visual acuity 6/24 on the right side and 6/6 on the left side. On diagnostic nasal endoscopy, there was no mass lesion seen. So the patient had done non-contrast computed tomography of nose and paranasal sinuses, in which it showed collection in the right maxillary sinus without any involvement of nose. On magnetic resonance imaging of orbit, nose and paranasal sinuses, there was hypointense opacity in T1 and isointense opacity in T2 with loss of fat plane and normal extraocular muscles and optic nerve. It was suggestive of orbital pseudotumor. The preliminary management included transnasal endoscopic middle meatal enterostomy and right transnasal endoscopic medial orbital decompression, and biopsy was sent, in which actually there was a black necrotic devitalized tissue seen in the right maxillary sinus intraoperatively. So samples had been sent for histopathological examination, Gram stain, Zn stain, and fungal staining. So the samples from both nose and orbit came out to be as same as the previous case, with suggesting of rhizomucor. The patient had developed new onset chemosis with sudden exacerbation of proptosis and vision loss during the hospital stay. So the patient had been given intravenous amphotericin B followed by tablet posaconazole, and then right orbital exenteration was done with aggressive endoscopic debridement. So, to compare between the two cases, The first patient was a 41-year-old male, and the second patient was a 48-year-old male, both being middle-aged males, with first patient having type 2 diabetes mellitus and history of COVID infection, and the symptoms were acute in onset. There was blackish discoloration of skin over the left cheek, and black necrotic debris was seen in the left nasal cavity. So T2 was showing hyperintense opacity. So clinically, radiologically, it was strongly suspicious of mucormycosis. So amphotericin B had been started empirically. In the second case, the patient was immunocompetent with no history of diabetes or COVID infection. The symptoms were subacute in onset. Diagnostic nasal endoscopy was found to be normal. So clinically, it could be any orbital malignancy. And then radiologically, it was hypointense in T1, and T2, it was isointense opacity of orbit. There was no involvement of fat plane. So radiologically, it could have been a pseudotumor of orbit. But during the intraoperative period, there was a black necrotic mass seen in the maxillary antrum. So following that, there was a strong clinical suspicion of mucormycosis, and then amphotericin B had started, and then after microbiological confirmation. Diagnosis of sino-naso-orbital mass can be challenging due to wide pathological variations and clinical features, leading to potential morbidity as well as mortality of the patients. There have been instances where mucormycosis has occurred in immunocompetent individuals without the presence of risk factors. So early diagnosis and treatment with correction of predisposing factors and regular aggressive surgical debridement and prompt antifungal therapy are keys to survival of the patient with mucormycosis. These are the follow-up pictures of both the patients, and both patients were doing well currently. So take-home message is, mucormycosis should be considered as a differential diagnosis in atypical sino-naso-orbital mass, even in an immunocompetent patient in this post-COVID era. These are my references. Thank you.
Thank you, Dr. Kiran. It was a good presentation. But one thing I must ask you, whether when the patient came to your OPD as a first person to see a doctor, would you advise him or her to go to the medical ward first and have some antifungal therapy and then come to you, and then you take the patient to the OT or like that? Or you just straightway go take the patient to the OT? Is there any medical, treatment beforehand? Or first surgery, then medicine?
Sir, we will first investigate by doing a diagnostic nasal endoscopy.
No, you have just diagnosed a case of mucormycosis.
Okay.
What is the next step?
Sir, if it's diagnosed already, then we should start the amphotericin B as soon as possible, and then go for debridement.
How long will that antifungal therapy you just continue before going for surgery? Is there any time limit or like that, something?
So we can give for 4 weeks, and then simultaneously we can go for surgery, sir. And then follow up with
again medical therapy. Again medical therapy.
Yes, sir. So if there is a strong clinical suspicion, then we start the amphotericin.
Debridement.
Yes, sir. Debridement simultaneously with the medication, sir.
What is the adverse effect of amphotericin B?
Adverse effects, sir. It can cause it is a
very bad effect.
Nephrotoxic, and it is a hemotoxic drug, sir.
So what is the basic goal of doing the surgery?
Excuse me, sir?
No, what is, like, for functional endoscopic sinus surgery, you do a mucosa preserving, ventilation improving, mucociliary clearance improving surgery. But what is the primary goal here?
So primary goal is to remove the fungal debris and till we reach the normal mucosa.
Yeah.
And if there is a bleeding points that we see, till there we would do the surgery.
So you get rid of all the dead
Yes,
tissue,
sir.
fungal debris,
Yes, sir.
and leave normal tissue so that the amphotericin can reach.
Yes, it can
That is the-
penetrate into the tissues.
Thank you.
Nothing specific. What was the presentation of your second case?
So presentation.
With what complaint the patient presented to you?
So,
The second case.
So, second case,
Yeah.
he complained of a right orbital swelling, and then with gradual loss of vision, sir.
Was it referred from the eye department or
No, sir. It was,
came to the ENT
Yes,
directly?
sir. Yes, sir.
Huh?
So we had thought it to be like some orbital malignancy at first,
Yeah.
and then we did the diagnostic nasal endoscopy. There was no finding, sir. But then once we did the surgery, and then in the right maxillary sinus, we had seen some blackish discolor.
Now, before that, you had the MRI or CT imaging.
Yes, sir. We had
Yes,
done the
yes,
MRI where it was like.
Didn't you consult any ophthalmologist before?
Yes, sir.
going?
In collaboration with ophthalmologists, it was done. Orbital exenteration was done, sir.
Orbital exenteration, no. Decompression of the orbit and biopsy was the first step.
Yes, sir.
Wasn't it?
Yes, sir.
Okay.
Thank you. Any comments from the audience? Mike.
Regarding protocol of the treatment of the mucormycosis, particularly in the post-COVID era, it was previously discussed also, that whenever there is a patient presenting with a strong suspicion of mucormycosis, like redness of the eye, chemosis, or black nasal discharge numbness, at the very beginning we do MRI before doing any other thing, and definitely by COVID and the serology was done, and then MRI, and on strong clinical suspicion we start amphotericin, report out, and send and do nasal endoscopy, send for the which smear and the culture and the biopsy from the tissue available from the nose. And when the report came, then we will continue the treatment, or if not, then we will rethink or justice about the patient. And then we go for the main operation. Then the treatment will continue for 4 to 5 weeks, depending on the criteria. And then definite treatment, and followed by redebridement time to time, usually 2 to 3 times for the more debridement of the tissues, and then posaconazole. This is the protocol followed in Kolkata all hospitals.
Thank you. Thank you. We can take one more comment if anyone.
But I have seen a few more cases of in my career. I have never seen any case having mucormycosis infection who is not diabetic, number one. And number two, is the second case that you have shown is a strong, healthy man. How he has got the infection of mucormycosis? What is the reason? Do you explain for that? Your second case was a young man. He's not having any diabetes or any other disease. But how he has got infection of the mucormycosis? How can you explain?
I think what I understand, sir, that in the post-COVID era, there are more and more immunocompetent patients are
That
getting
is what
this
I am
mucor-
saying. That,
And probably the theory is that for some illness or something, they are made temporarily immunocompromised,
Immunosuppressed.
which is not detected, and then opportunistic fungus goes, and
Yeah.
but otherwise they are labeled as immunocompetent. I think that's the theory which has evolved now.
Steroids.
Pankaj da, কিছু বলবে?
May I now request Professor Ramanuj Sinha to kindly give the certificate to Dr. Kiran Konkal Marak.
Just
Our next speaker is
my
Dr.
take
Somnath
on-
De.
My take on what Professor Rajudri and Sir has said, in exactly the mechanism of an increased mucormycosis infection in the COVID era was not directly related to immunocompetence. It had other many mechanisms, which I am not now enumerating here, and probably in the post-COVID era, those mechanisms are subclinically are also operating, and really during the COVID era, we saw many mucormycosis in not immunocompetent subjects, and probably there is the same reason that why even in the post-COVID era, you are getting these cases. So, Amitabh, do you agree with me?
Yeah, take.
But regarding the protocol that you have said that because the main problem with mucormycosis is a necrosis and avascularization of the tissue. So you give any amount of antifungal drug, it will not reach the fungus there. So debridement is probably the primary thing that Professor Amitabh Raychaudhuri was asking. That is the first thing to be done. And vis-a-vis and amputation B should be started because that will take care of any fungus then disseminating into the systemic circulation. But giving amputation B quite prior to the surgery, I think it is a wastage of money and also risking the patient for his nephrotoxicity.
Okay, we shall discuss it. Sudeep, we shall discuss it later on. Just carry on. This is the last speaker. Please carry on.
Good afternoon, everyone. My senior teachers, judges, my colleagues, and my juniors. Today, I am sharing my experience on an unusual presentation of an frontal sinusitis. Here, a 15-year-old girl presented with intermittent swelling of her forehead, and she was having this symptom for last 6 months in her OPD. She went to multiple doctors. She had courses of antibiotics and also other conservative medications. Till then, no imaging was instructed by the previous doctors. We took the thorough history of this patient, and there is nasal discharge and nasal blockage associated with frontal headache, and she was having loss of smells also. And as I told earlier, she was having a swelling of her forehead, pain over the swelling was there, and she was also complaining of heavy-headedness. At the time of this presentation, she was having fever also. So we admitted this patient and we did the routine blood test, and the total leukocyte count was raised, along with ESR and CRP was also high. We went for diagnostic nasal endoscopy and there is no abnormality found. And then we went for the CT scan of PNS, where we show that the heterogeneous collection in the frontal sinus, and there is a defect in the anterior as well as the posterior table. So we went for a CT scan of face with 3D reconstruction, and there a punched out defect was there in the frontal bone. And there is a pocket of extradural collection was there in MRI of paranasal sinus and brain. So here is a defect. Here is a defect, anterior table and the posterior table, and in this CT scan we has shown the heterogeneous collection over there. This is a CT scan face with 3D reconstruction. This is a punch out defect which is indicated by a green arrow in the frontal bone. And this is an extradural pocket which is actually pushing the forebrain towards posteriorly. So after doing the necessity test, like preoperative test, we put this patient for definitive surgery. We obviously put this patient under general anesthesia, and we went for a combined approach, that is external as well as internal approach. In external approach, the steps are, we made a Lynch-Haworth incision, and the subperiosteal flap was elevated. The cortical bone over the frontal sinus was drilled out, and the extradural necrotic pocket material was identified. The communication with this frontal recess was identified, and 2 by 2 centimeters necrotic pocket material was expelled out from there, and the exposed dura was identified. And this exposed dura was lately confirmed by this endoscopic view also, and we converge this extradural space with the frontal sinus lately. Now, these images is a Lynch and Haworth incision we made over there. The subperiosteal flap has been elevated. This is a necrotic pocket material. This is necrotic pocket material which has been identified, and this marking where we drilled out for the frontal sinus. This is a communication between this extradural space and the frontal sinus. These are necrotic material which we removed. Agar cells up to the lateral edge of the middle terminate. So draft 2A procedure was done, and ultimately we identified the frontal sinus. This video has shown the lamina papyracea here and the middle terminate, and draft 2A procedure was done. And this is actually, we are showing that from inferiorly to the frontal sinus, and this merocil pack is removed from externally. Now come to obliteration. At least there is a big cavity, so we had to obliterate it. But before obliteration, we stripped up the mucosa over the cavity, and then the fascia lata was placed over the exposed dura in the frontal sinus. We obliterated the space internally and externally also. The fat globules and the surgicals were used, and ultimately we packed with merocil. This video is showing that the obliteration is being done endonasally by a 0-degree endoscope and 70-degree endoscope, and this obliteration is being done externally. So this is the final image after obliteration. For smoothing of the surfaces, we used bone wax over there. And now come to histopathology. In histopathology, we found that necrotic material, neutrophilic infiltrations was there, and also lymphocytes and plasma cells is there in the background of edematous mucosa, edematous stroma. So all are features of chronic inflammation. Now, in follow-up, this is a smiley face of my patients with disappearing scar, and this snap has been taken after 3 months of surgery. So what should be our take-home message? The take-home message should be, we should ask for the symptomatology of chronic sinusitis and chronology also, and the proper imaging modality has to be done to assess the extent of the pathology and anatomical details, and the proper surgical planning should be there to prevent the recurrence and to remove the disease in toto. Thank you.
Thank you, Dr. De.
Thank you, sir.
Very nice and interesting case. I have 1 or 2 questions. One is, like when you identified the area after giving the incision on the frontal bone, how did you decide where to drill? Is it just by looking at the pocket, or did you use any anatomical landmarks?
Sir, actually we use that CT scan and MRI over there, because there is a pocket, and after that below just 2 to 3 centimeters there is a place for frontal sinus also. So we marked over there and drilled it.
For sake of discussion, if there was no punched out bone and you had to open from that side, what would be your identification landmarks, and what help can you take from technology?
See, this is not actually classical Lynch Howard incision we have done, because this is actually
modified.
trephination, yes, modified here. But this incision is being used for trephination, frontal sinus trephination. But in case of Lynch Howard incision, we made an incision over the medial aspect of the medial canthus, and we extend 2 to 3 centimeter, and from there, and we marked the frontal sinus with this thumb, with this index finger, and there is at least in a 2 o'clock position the frontal sinus is there. If we opened it or drill with something, so we can find out the drainage pathway of the frontal sinus.
Okay.
So this is not done classically.
Any other things that you can take help of? Very old and modern, both.
To identify the frontal sinus externally?
Osteoplastic flap?
Osteoplastic flap.
You can take a template and mark it and then identify.
Yes.
Or you can use image guided, I think.
Yes.
Thank you.
Thank you, sir.
So what is unusual here? Unusual presentation.
Sir,
what is the unusual presentation here? Clinical, not radiological.
The swelling was, first of all, the swelling was just intermittent. and the pain was just waxing and waning with the medications. First, look, when we see one complication of the frontal sinus, so obviously we will think about the porphyry tumor, right? But porphyry tumor is not like there because the subperiosteal abscess was not there. So and also there is no sequestrum was found in the histopathology also. So we can't tag it with that is a porphyry tumor. It's a tumor which it's a complication of frontal sinusitis which actually gone to the extradural space, and this is actually large, a big cavity we have found over there.
Okay. Did you find any bone debris?
Bones, sir?
Bones, spicular debris like that?
No, that's why
No
I'm saying.
bone.
No.
So no osteomyelitis
Just
like
it is nothing but just that polypoidal tissue with some sort of smell, but we didn't find any bone over there. No pus also. So
what would have been the neurological complications in your case if untreated? Because it was,
look, yes.
One or two.
Yes, sir.
Very important.
Any complication of frontal lobe, the frontals, if patient would be should have some confusions, cognitive behavioral changes, and memory loss also there, because imagining restraining also is doing by this frontal lobe.
Any meningeal irritation? Because dura meninges has been involved.
Yeah, meningitis is
maybe sometimes.
Maybe.
Okay.
Any comments from the audience? Mic ta dao.
In your case of frontal sinusitis,
yes, sir,
it is infective, isn't it?
Yes, sir.
How this infection in the frontal sinus has eroded the anterior wall, which is so thick? Why not the posterior wall is eroded and it has gone into the...
Posterior wall is also eroded. That is the unusual thing of this case. Yes, sir. Sir, I have shown a slide. Yes, sir.
May I request Dr. P.B. Roy to kindly come on stage to give the certificate to Dr. Somnath De.
There are two announcements. I request...
Sir, here, the...
Certificate ta diye do.
I call upon stage Dr. Ajay Mollik sir, head of the department, Kollani AIMS Hospital, and Dr. Harsh Dhar to announce their programs. There will be a program on 8th of July. 8th July on World Allergy Day.
We will be on celebrating World Allergy Day on 8th of July, as you all know, at AIMS Kalyani, and we have with us our own AOI West Bengal President Doipan and Dr. Subir Jain from Indore. So I would request all of you all to please come and grace the occasion. We will be sending the invites and preliminary, messages to all in the group. So Doipan has very kindly consented to come in his busy schedule, and Subir Jain will be coming from Indore. So I request all of you all to please come there. Thank you.
I would like to invite all of you, all of our members of AOI West Bengal to the upcoming thyroid conference. Dates are 7th, 8th and 9th June. We've already shared all the promotional material with everybody in the hall. And it's the 6th edition of the National Indian Society Thyroid Surgeons Conference. It's a national conference. It's being graced by 3 very eminent international faculty, including Professor Kyung Tae, who has pioneered robotic thyroid surgery. And we're going to have 7th will be live surgery workshop, including cadaver dissection at SSKM and a surgical workshop at our hospital in Medica. We are still awaiting NMC permission for live surgery. If not live surgery, we'll be having video-based surgical discussions. And on 8th and 9th, we'll be having the full thyroid sessions at the Taj, new Taj, which is opened up near Eco Park. So inviting all of you, especially the youngsters, we still have spots available for observers in the cadaveric dissection. In case students are still interested, please get in touch with me. I will please make sure that you all are taking your spots. And this is again in collaboration officially with AOI West Bengal and also with our FHNO. So big thanks to everybody in the AI group, Snehashish Da, Doipan Da, Amitabh sir, Arunabh sir as our organizing chairman. So welcoming you all, and just 3 weeks left, lot of work to be done, but hope to get all of your support. Thank you.
Thank you, Horst. Okay. And Horst actually আমাদের দুজন স্টুডেন্টকে কমপ্লিমেন্টারি করেছে, তিনজনকে, ওই যারা টেম্পোরাল বোন ডিসেকশনে ফার্স্ট সেকেন্ড হয়েছিল তাদেরকে। আর I thank all of you for being here and hope you have all enjoyed the program. And I thank the authorities of Vivekananda RKM Vivekananda Institute of Medical Science for giving us the opportunity to organize the program here under the leadership of our president, Dr. Amitabh Rai Chaudhary, and his team. And I also thank Sun Pharma Stancare Division for supporting us in organizing this program. Our next clinical meeting will be on 29th of June at CMRI Hospital. So, হ্যাঁ, জাজেসদের তো ধন্যবাদ দিয়ে শেষ করা যাবে না, মানে স্যার এমনিতেই এত প্রোগ্রাম হচ্ছে, মানে দম ফেলার সময় নেই স্যার। মানে এর মধ্যে আপনি চিন্তা করবেন না, আরো মানে আমাদের এমনিতেই এখন যা হয়েছে, আমাদের এওয়াই ওয়েস্ট বেঙ্গলের প্রত্যেক মাসে একটা করে প্রোগ্রাম থাকছে, এওয়াই ওয়েস্ট বেঙ্গলের প্রোগ্রাম। এছাড়া হচ্ছে বিভিন্ন কোম্পানি আরও অন্যান্য প্রোগ্রাম মিলিয়ে প্রত্যেক মাসে 2-3টে করে প্রোগ্রাম হবে, যার জন্য আর কি খুব চাপের। তবে আমাদের
অ্যাকচুয়ালি এই যে ক্লিনিক্যাল মিটিংগুলো আগে আমরা যখন ছোটোবেলায় দেখেছি আর কি, যখন স্যারেরা অর্গানাইজ করতো, তখন অ্যাকচুয়ালি ইন্টারেস্টিং কেস যেগুলো ছিল সেইগুলো প্রেজেন্টেশন হতো এবং সবাই পার্টিসিপেট করা হতো, সেটাতে ডিসকাশন হতো সেই ইন্টারেস্টিং কেসগুলো নিয়ে। এখন একটু চেঞ্জ হয়ে গেছে, নিশ্চয়ই চেঞ্জটা তো করতেই হবে দরকার, কিন্তু আমার মনে আরও মানে যারা সিনিয়র মেম্বার আছে তাদের যে এক্সপিরিয়েন্স সেগুলো আমাদের শোনা দরকার আছে। এবং সেখানে আমার মনে হয় একটা জিনিস আমরা করতে পারি যে অনেক সময় অনেক থিওরিটিক্যাল কেস আমরা এখানে দেখতে পাচ্ছি আর কি, আর সেইগুলো না করে যদি অনলি দ্য আনইউজুয়াল কেসেস যেগুলো আমরা ক্লিনিক্যালি পাই প্র্যাকটিক্যাল ইউনিটের, সেই কেসগুলো যদি প্রেজেন্ট করা যায় এবং সেইগুলো যদি আরেকটু ডিসকাশনের সময় বেশি থাকে, তাহলে আমার মনে হয় আরেকটু থস হতে পারে।
এটা একটা কারণে এত প্রেজেন্টেশন কেন আসছে এটা আগে ভাবতে হবে আমাদেরকে, এটা কেন আসছে। দ্য মেইন থিং ইজ দ্য এনএমসি। দেয়ার যে এভরি স্টুডেন্ট শুড মেক এ প্রেজেন্টেশন ইন এ প্ল্যাটফর্ম। That's why we should give chance to every student in a step-by-step manner. Okay. Thank you, everyone.
Thank you, everyone. The meeting is called off. আমরা CMRI তে দেখা হবে। হ্যাঁ, ওদের ডাকছিলাম তো, এই তো না they have come. উপরে যাও না, উপরে যাও। So I have the team member from Sun Pharma, Stand Life, who has given us sumptuous meal today. I want them to say something.
Sir, thank you very much. Thank you very much, West Bengal AOICON for giving us this opportunity to be a part of such a fantastic academic program. And in future also our endeavor will be to be getting associated with with West Bengal AOICON. Thank you on behalf of Stand Life, Sun Pharma, and our one and only request would be for Mosque Lab. Thank you sir, thank you very much.
Thank you everyone for coming in large numbers and encouraging. Next মাসে মিট হবে আমাদের আবার, তাই তো?